Hello, hello. Right, Beta. So now let us start with the systemic surgery story. And I hope you've nicely understood the first six chapters, except the chapter three. Right. So we have got some nice concepts which we try to make in general surgery. And now the systemic surgery, the pediatric adult oncosurgery, this is full of concepts, concepts, and concepts. Once you have got the concepts nicely there inside, then you will not find any challenges in systemic surgery. As we can see, the indexing in systemic surgery has been done in such a way so that the pathologies are divided into the pediatric age group, the adult age group, and the elderly age group. And these pathologies, what we are going to discuss in these chapters, will be in a sequence right from top to bottom, so that we get a nice clarity, and this might help us in solving the different clinical questions on 17th of December. And not only this effort might also help you a lot in your clinical practice when you will be working in the hospitals from February 23. So my dear friends, first of all, let us take a look at what all we are going to discuss in the pediatric surgery. That means we are going to discuss about the surgical pathologies in children, and going in a sequence from top to bottom. We'll be starting with the stories of the face, where we'll be talking about cleft lip and palate. We'll be going down into the neck, where we'll be talking about different swellings in the neck like thyroglossal cyst or fistula, branchial cyst, cystic hygroma. Then we'll move into the thorax area, where we'll be talking about esophageal atresia. Then we'll be going into the abdomen, and in the abdomen again we'll be going in a sequence like this area. This is epigastrium. This area is right hypochondrium. This is left hypochondrium. This is the umbilical region. This is the right lumbar or lumbar region. This is the left lumbar region. This area is the hypogastrium. This is the right iliac. This is the left iliac region. So what we'll be doing is we'll be going down in a sequence somewhat like this. Like this. Here in the epigastrium, we know God has given us the stomach duodenum. So we'll be talking about the stomach duodenal stories here. In the right hypochondrium, there is liver and gallbladder. So we'll be mainly focusing on the liver gallbladder problems here. In the lumbar region, we'll be talking about the kidney problems mainly. In the right iliac fossa, we'll be talking about the intestinal issues on the right side. In the left iliac fossa, we'll be talking about the intestinal issues on the left side. In the hypogastrium, we'll be talking about the ureteric and the bladder issues. Then we'll be talking something issues in the urethra like posterior urethral valve and hypospadias. And finally, we'll be signing off this pediatric surgery with discussion of scrotum, that is undescended testis or cryptorchidism. Now, as we have been talking about that each and every word what is written in these workbooks, that can be asked as a question in your exam. But still, if we focus on that what are actually the most important areas from where we can get the question in our exam, we might get a question from this esophageal atresia, then anything here, something may be related to Meckel's or Hirschsprung, and the scrotum. These are going to be the most hot areas in pediatric surgery. Right, beta. So now, if we try to look from above downwards, what I want all of you, beta, when in the month of November, you will be revising your surgery, pediatric surgery, you should be able to revise this entire pediatric surgery just by looking at this indexing in 1 hour, maximum 1 hour. You should be able to revise the entire pediatric surgery just by looking at this indexing. Okay, that is where we want to reach. Now, let us take a look at what all we need to discuss in the facial stories. So, in the face, if we talk about small babies, what can be the surgical problems? You may come across babies with something like this. This you can nicely appreciate. There is a cleft in the lip. Now, beta, this is unilateral or bilateral. So, this is a unilateral. This is right side, this is left side. So, this is a left-sided cleft, right? Cleft of the lip. Now, this cleft, is it complete or incomplete? If this cleft is extending inside the nose, अगर ये nose के अंदर जा रहा होता, then we would have called it as complete. But if it is not going inside the nose, then it is incomplete or partial, right? Now tell me, beta, what is this? Is it unilateral or bilateral? Very good. So it is bilateral. Is it complete or incomplete? Very good. So it is incomplete. Right. So let's have a big round of applause for all of you, because what is relevant for 17th of December here, we might get an image-based question where they may ask us to identify what is this pathology. So this, what we are seeing on the screen, this is a bilateral incomplete cleft lip. Now, if we look at some other images, beta, this looks to be a complete cleft lip on the left side. This looks to be a bilateral complete cleft lip. And this, we may not be seeing this nicely, but this is actually a cleft in the palate. So this is a cleft palate. Sometimes we come across that babies are born with either cleft lip or cleft palate. Out of all this, beta, cleft palate is something which is most common 45% of the time. Then usually this cleft palate is actually associated with cleft of the lip as well. 40% of the times we can find just cleft palate alone, and 15% of the times we can find just cleft lip alone. Usually the clefts in the lip, they are more common on the left side. Why these problems occur during intrauterine life? Either they may be related to some genetic issues, some mutations, or in the environmental factors. Suppose the pregnant female was having epilepsy, or if she is taking some anti-epileptic drugs, or maybe she is taking some steroids, then the chances of cleft lip palate are high. There is one syndrome which can be associated with this cleft palate, that is a Pierre-Robin syndrome, where we may find isolated cleft palate, retrognathia, and glossoptosis. What will be the problems to this baby if there is a cleft in the lip or cleft in the palate? Now, the baby will have problems in feeding. Baby will not be able to close the lip properly, so feeding might be a challenge. Airway might be a challenge sometimes. Speech and dentition are the other challenges with these cleft lips and palates. So as a doctor, we need to make the diagnosis, though it is a clinical diagnosis. If we are seeing the baby, we can easily see these cleft lips and palates. During intrauterine life also, we can diagnose the cleft lip. Suppose you are doing an ultrasound in a pregnant female. Now, when you are doing the ultrasound, the baby might be seen something like this, and you can see that cleft of the lip on antenatal ultrasound after 18 weeks of pregnancy. But you will not be able to see cleft palate on antenatal ultrasound, that is ultrasound during pregnancy, because for that, to see the cleft palate on antenatal ultrasound, you want that the fetus should keep the mouth open like this. But even if you ask the fetus to open the mouth, the fetus does not listen to you, right? So we can diagnose the cleft lips on antenatal ultrasound, but we cannot diagnose the cleft palates, right, beta? We definitely need to do treatment for these cleft lips and palates. We have to do surgeries. There is no medicine which can close these cleft lips or palate. And in surgeries for the cleft lip, we can repair these cleft lips somewhere around 3 months of age, when the baby is 3 months old, soft palate at around 6 months, and hard palate at 12 to 15 months. Right, so let's take a look what all is written here in this workbook, beta. Most common congenital anomaly of orofacial structure is a combined cleft lip and palate. So I hope we all are able to understand, beta. CL is written for cleft lip and CP is written for cleft palate. It is the combined cleft lip and palate which is most common. 45% of these anomalies are combined cleft lip and palate. 40% it is the cleft palate, and 15% it is the cleft lip. When we talk about cleft lip, beta, left-sided are more common. Reason for these cleft lips and palate, they may be genetic or environmental factors, like during pregnancy if the mother is having epilepsy, if the mother during pregnancy is taking some medicines like anti-epileptics, phenytoin, diazepam, or maybe steroids. A syndrome which can be associated with this cleft lip and palate is a Pierre-Robin syndrome. This is isolated cleft palate, retrognathia, and glossoptosis. Glossoptosis is a posteriorly displaced tongue. Problems: airway problems, breathing problems, swallowing problems, dentition problems, and speech problems. You can make a note. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks. Treatment, obviously we have to do some plastic surgical reconstruction. If we focus on when should we repair these cleft lips and palates, for cleft lip the ideal age is 3 months, usually between 3 to 5 months. The name of the operation what we are doing for cleft lip are Millards and Waddell's. Soft palate is ideally repaired at 6 months, and hard palate is ideally repaired between 12 to 15 months. Right. Moving down from the face, if we take a look at the neck, small topics. Now in the neck, what all we can find, beta, if we just try to understand the story in the neck. Suppose this entire thing what we are seeing, this is the neck area. Now in this neck area, we may come across some swellings which are located in the midline. For example, there is a thyroglossal cyst which you can find in the midline. Sometimes there is a thyroglossal fistula as well. There may be a swelling which is located in the upper part of the neck. This may be a branchial cyst. Herein we should know that branchial fistula is located in the lower part of the neck. Sometimes we can find a cystic hygroma which is located in the posterior triangle of neck. So beta, what I have tried to do here is I have just tried to draw the neck, though it is not something which is good looking. But yes, we just imagine. Now in the center of the neck, if there is a swelling in a baby, this should be a thyroglossal cyst. Upper part of the neck, in a baby, we may find a branchial cyst. Lower part of the neck, here we may find a branchial fistula, and in the posterior triangle we may find a cystic hygroma. How these different swellings do occur, if we just try to understand those stories. Suppose, first let us try to see what is this thyroglossal cyst actually. This what you're seeing on your screen, beta, this is a thyroglossal cyst, right? If I take you into the intrauterine life, and if we try to understand, sorry, right, beta. So here in what we are able to see, this is, I'm just trying to demonstrate that during intrauterine life, there is something called as foramen cecum, which is located at the junction of anterior 2/3 and posterior 1/3 of tongue. During intrauterine life, a thyroglossal bud descends from this foramen cecum on the tongue, and this thyroglossal bud is descending exactly in the middle of the neck, in the center of the neck, and it goes right up to the lower part of the neck, where it unites with the two ultimobranchial bodies and forms the two lobes of thyroid gland. This what you are seeing, the white structure, this is actually the thyroglossal duct or the thyroglossal tract. Normally what happens, beta, before the baby is born, look at me on the screen, before the baby is born, this entire thyroglossal tract is obliterated. The entire thyroglossal tract is obliterated, so that after birth, there is no connection of the tongue with the thyroid gland. There is no connection of the tongue with the thyroid gland after birth. But sometimes what can happen, beta, if suppose this thyroglossal tract, which is descending exactly in the middle of the neck, if by chance this thyroglossal tract, or I'll use a little less thickness, suppose this is the thyroglossal tract, suppose this thyroglossal tract does not close even after birth and it remains patent like this, there is a possibility that sometimes some secretions may get collected somewhere in this thyroglossal tract, and because of collection of these secretions, the baby may present with some swelling in the neck. This is what is a thyroglossal cyst. Like here what you're seeing, beta, can you appreciate there is some laddu type of swelling in the middle of the neck? Important to note, this is exactly in the midline. These thyroglossal cysts are seen exactly in the midline. We know that all the thyroid swellings, they move with deglutition, that means they move with swallowing. But a characteristic feature of this thyroglossal cyst would be, since you can understand and see that this is actually also connected to the tongue. So when you ask this baby to protrude the tongue out, you can see the movement of this thyroglossal cyst. Because this thyroglossal tract is connected to the foramen cecum on the tongue, if the patient is asked to move the tongue out, this thyroglossal cyst also moves. That is how we can make the diagnosis of this thyroglossal cyst. Sometimes complications can occur in this thyroglossal cyst. For example, This is how the patients are presenting to us, or we can just imagine like this. This is the presentation here, beta. So this is the thyroglossal cyst. Sometimes what will happen, because of stasis of secretions, stasis, again the same concept, beta. Wherever there is stasis, there is risk of infection, bacterial party. वही वाला कंसेप्ट लगाना बेटा, जब जब कहीं पे भी रुकावट होगी तो वहां पे इन्फेक्शन होने का खतरा बहुत ज्यादा होगा। नदियों को देखें और तालाबों को देखें, नदियों में पानी बहता हुआ होता है, तालाबों में पानी रुका हुआ होता है, इसलिए नदियां साफ होती हैं, तालाब गंदे होते हैं। We are just trying to understand the concept of stasis. Like if we look at the rivers versus the ponds, since water is freely flowing in the rivers, they are clean, but water is stagnant in the ponds, so they are dirty. The same story here. If there is stasis of secretions in this particular area, the chances of infection will be high. And there is a possibility that this patient may present with an abscess in the neck. Now, if there is an abscess here, if there is an abscess developing in this area, there would be pus inside this. Sometimes this abscess can rupture into the skin. If it ruptures into the skin, it will create a hole in the skin. And if you look at this hole in the skin, outside there is a connection with the skin, and inside it is connected with the thyroglossal tract. So abnormal relationship will develop between the skin and the thyroglossal tract, and abnormal relationship between two people is called as, very good, fistula. So if this abscess ruptures into the skin, it becomes a thyroglossal fistula. Or sometimes, beta, suppose this thyroglossal cyst patient has developed abscess here, and this patient comes to you in February 23, and you are seeing that, oh, there is an abscess, and as we know that पस को देख के सर्जन को कुछ कुछ होता है. As soon as you see the abscess, you are tempted to make an incision and drain this abscess. If you make an incision and drain this abscess, beta, you actually communicate this to the skin. So again, there will be abnormal connection between the skin and the thyroglossal tract. So either this abscess ruptures spontaneously or incised by the doctor, it becomes a thyroglossal fistula. Thyroglossal fistula is something which is not present from birth, but it is always acquired. Rarely, if this cyst is present here for a long period of time, another complication can develop, that is a papillary thyroid cancer can occur in these thyroglossal cysts. Papillary thyroid cancer can occur in thyroglossal cysts. In the treatment, there is no medicine which will be able to take care of this thyroglossal cyst. We know just by removing the cyst also, the problem is not going to be solved, because the problem is actually the persistence of this tract, which God used to obliterate before birth. If God has not obliterated it, that is the reason why the secretions are getting collected and the patient is presenting with a cyst. So in the treatment, we not only have to remove this cyst, but we actually have to remove the entire thyroglossal tract right up to the base of the tongue, and that is called as Sistrunx operation. Sistrunx operation. Now let's see what all is written here. Thyroglossal cyst is basically persistence of thyroglossal tract, wherein there may be accumulation of secretions anywhere in the thyroglossal tract. This is always seen in the midline, commonly presents in children, Most common location of this thyroglossal cyst, here is the hyoid bone, and this thyroglossal cyst is most often seen below the hyoid bone, beneath the hyoid. This consists of cholesterol crystals, just like we can find the cholesterol crystals in branchial cyst and hydrocele fluid. Most commonly, how these babies present to us, there is a swelling in the middle of neck, swelling in midline of the neck, which move with deglutition, and a characteristic feature of these thyroglossal cysts, it also move with protrusion of tongue. It also move with protrusion of tongue. Sometimes complications can occur. For example, infection can occur which may lead to abscess. Abscess can rupture, and this will result in thyroglossal fistula. Thyroglossal fistula is never congenital. It is always acquired. And sometimes in the complications, cancer can occur, and it is the papillary thyroid cancer which can be seen. If you remember, in endocrine surgery, beta, we discussed about goiter, and long-standing endemic goiters can lead to follicular thyroid cancer, while long-standing thyroglossal cyst can lead to papillary thyroid cancer. And the treatment for this thyroglossal cyst or fistula will be cyst trunks operation. Cyst trunks operation. Herein, it is not only the excision of cyst, but it is also the excision of thyroglossal tract. सिर्फ cyst निकालने से बात नहीं बनेगी बेटा, अपने को पूरा का पूरा thyroglossal tract निकालना पड़ेगा, right up to the foramen cecum on the tongue. This is what we call as cyst trunks operation. Just a passing reference about a ectopic thyroid tissue. Normally we know better that the thyroid gland is located in the lower part of the neck. The weight of the thyroid is approximately 25 grams. Sometimes we may find ectopic thyroid tissue. Ectopic means apart from the normal location, it may be present somewhere else. If this ectopic thyroid is present on the tongue, we call it as lingual thyroid. If it is present somewhere in the middle of the neck, we call it as median ectopic thyroid. If thyroid tissue is present on the tongue, most often it is found at the foramen cecum, that is the base of the tongue. So this is something which is different from a thyroglossal cyst. Ectopic thyroid, it is the thyroid tissue which is present. And thyroglossal cyst, it is a cyst which is having the kachara, which is having the secretions, right? So do not mix thyroglossal cyst with a ectopic thyroid tissue. Ectopic thyroid tissue is simply presence of thyroid tissue anywhere from the foramen cecum on the tongue to the isthmus of thyroid gland in the midline. If the ectopic thyroid tissue is present on the tongue, we call it as lingual thyroid, and most commonly on the tongue we find this on the foramen cecum. Foramen cecum is located at the junction of anterior 2/3 and posterior 1/3 of tongue. Anterior 2/3 and posterior 1/3 of tongue. Apart from this, we can even find the ectopic thyroid tissue in the middle of the neck, midline in the upper neck usually, and that is called as the median ectopic thyroid. Right. So apart from this thyroid swelling, if we take a look at other swellings in the neck, like branchial cyst and branchial fistula. So my dear friends, as you are able to see in this particular image, you are able to make out that there is something which you are seeing in this particular area, that is in the upper part of the neck, and you are seeing something in the lower part of the neck here. Now, fistula is a communicating rasta between two people, right? Actually, whether it is a cyst or a fistula, both are related to the second branchial cleft. This also and this also is related to second branchial cleft. Both are located on the anterior border of sternomastoid muscle. Now, sternomastoid muscle is this, right? So, cyst is located here and fistula is located here on the anterior border of sternomastoid muscle. Only difference is cyst is located in the upper part of the neck and fistula is located in the lower part of the neck. Cyst is lined by squamous, fistula is lined by ciliated columnar. In fistulas, if the external opening is in the skin, the internal opening is located near the tonsil inside on the anterior aspect of posterior fascial pillar behind the tonsil. The treatment for both branchial cyst and branchial fistulas would be complete excision. Right. So, branchial cyst and branchial fistulas, beta, this is a remnant of second branchial cleft. This is also a remnant of second branchial cleft. Both are located on the anterior border of sternomastoid, cyst in the upper neck and fistula in the lower neck. Cyst is lined by squamous epithelium. Fistula is lined by ciliated columnar epithelium. The internal opening of the fistula is found on the anterior aspect of posterior fascial pillar behind the tonsil. The treatment for both branchial cyst and branchial fistula is complete excision. Apart from this, we have read two things about branchial cyst earlier. They may contain cholesterol crystals like thyroglossal cyst and hydrocele fluid. Branchial cyst may also show positive transillumination sometimes, though cystic hygroma is the most brilliantly transilluminant swelling. However, ranula, hydrocele, meningocele, and rarely branchial cyst may also show positive transillumination. Right, beta. Another swelling in the neck is a cystic hygroma. As we were discussing earlier, during intrauterine life, sometimes what can happen, there may be sequestration of the lymphatic channels in the jugular lymphatic sacs region, and this will lead to huge amount of lymph collection in these jugular sacs. Sometimes they may become so large that they may even obstruct labor. That means when the baby is coming out from the mother's vagina in normal vaginal delivery, then sometimes these cystic hygromas are so big in size that they can even obstruct the labor process. The baby can get stuck at the vagina because of these large cystic hygromas. 50% of the time, we can find this type of story. Now, this is a picture what we see in cystic hygromas. There's a big swelling. Usually this is arising in the posterior triangle of neck. And one thing which we know about them, because they contain clear lymph inside, they are brilliantly transilluminant. Let's try to see if we can have any other picture of this. Right. So these cystic hygromas, they are most often seen in the posterior triangle of neck. We are not able to find any in the picture for this. This is due to sequestration of jugular lymphatic sacs. There is lymph inside. These are vessels, beta. You know, artery, veins, lymphatic. The innermost lining of the vessels is called as endothelium. Whether it is artery, vein or lymphatic, they are lined by endothelium. And they are most brilliantly transilluminant. %50 of the time, these swellings are seen in the newborn baby, and sometimes they can obstruct labor. The treatment again for these swellings should be complete excision. However, sclerotherapy with Picibanil OK432 has been tried. Now, if we just try to remind ourselves, beta, in varicose veins, we talked about various sclerosing agents like foam, phenol in almond oil, ethanolamine oleate, sodium tetradecyl sulfate, tetracycline, polidocanol escarole, and Picibanil OK432. Right? So these are the various sclerosing agents which we can use here and there. Right. Another swelling here is chemodectoma. Now, chemodectoma is also called as potato tumor. Potato tumor. This is actually a carotid body tumor which originates from the chemoreceptors at the bifurcation of common carotid artery. Common carotid artery is bifurcating. The chemoreceptors present here. Sometimes we can get a tumor from those chemoreceptors, and that we call as carotid body tumor or potato tumor. In ENT, we read something about potato nose. Potato nose is rhinophyma. In ENT, we talk about hot potato voice, which is seen in quinsy or peritonsillar abscess. Right. So you can just make a note here, beta. Chemodectoma is a potato tumor, a term called as potato nose. This is seen in rhinophyma, and when you'll be learning your ENT classes, then you'll come to know that this is because of hypertrophy of sebaceous glands. There is a hot potato voice. This can be seen in variety of conditions. Out of them, one condition is quinsy, again a ENT problem, that is peritonsillar abscess. Just because the name was interesting, so I thought to include this in our discussion. Potato tumor is chemodectoma, arising from the carotid body chemoreceptors. Right. So, if we just try to summarize, beta, what all we talked in the neck swellings. We talked about this thyroglossal cyst and thyroglossal fistula. We talked about a branchial cyst and a branchial fistula. We talked about a cystic hygroma and a passing reference about chemodectoma potato tumor. Just to revise this neck chapter, neck topic, the thyroglossal cyst, they will always be seen exactly in the middle of the neck. That is because the thyroglossal tract, which starts from the foramen cecum on the tongue, it descends exactly in the middle of the neck, and in the lower part of the neck, it unites with the two ultimobranchial bodies and forms the two lobes of the thyroid gland. Usually, the thyroglossal tract completely obliterates before birth, so after birth, there is no connection of your tongue with your thyroid. But if by chance this thyroglossal tract remains patent even after birth, then secretions can get collected anywhere in this thyroglossal tract and they may present as a cyst. That is what we call as thyroglossal cyst. It will be seen in the midline. Most commonly it is seen beneath the hyoid bone, beneath the hyoid in children. The patient or the boy or the girl may present with a midline neck swelling, which moves with swallowing or deglutition. A characteristic feature of these thyroglossal cysts would be this will also move with protrusion of tongue, right? So that is how we can make out. Sometimes these cysts can get complicated because of stasis of secretions. Abscess can form and abscess can rupture. If abscess is incised, then also it will become a fistula, thyroglossal fistula, outside communicating with the skin, inside communicating with the thyroglossal tract. Sometimes papillary thyroid cancer can occur, and the treatment for these thyroglossal cyst or fistula should be complete excision. Not only the cyst, but also the complete thyroglossal tract should be excised. Sorry. And this is what we call as cyst trunks operation. Regarding the branchial cyst and the branchial fistulas, both are related to remnant of second branchial cleft. Both are located on the anterior border of the sternomastoid muscle. Cyst is found in the upper neck. Fistula is found in the lower neck. Cyst is lined by squamous. Fistula is lined by ciliated columnar. Internal opening of this fistula is located on the anterior aspect of posterior fascial pillar behind the tonsil, and the treatment would be complete excision. Whether it is cyst, you have to excise it completely. Fistula also has to be excised completely. Another swelling in the posterior triangle of neck, cystic hygroma. This is due to sequestration of lymphatic sacs, jugular lymphatic sacs. They get collected and they store lymph inside. Sometimes these cystic hygromas can become so large that they can even obstruct the labor process. 50% of the times they present in the newborn baby. Since these are lymphatic swellings, they will be lined by endothelium, and since there is clear lymph inside, they will be brilliantly transluminant. Most transluminant swelling in the body is a cystic hygroma. The best treatment for them would be a complete excision. However, we can also try giving sclerotherapy by Picibanil OK432. And we talked about a passing reference about the potato tumor or the chemodectoma, which arises from the chemoreceptors, the carotid body near the bifurcation of common carotid artery. Potato nose, rhinophyma, hypertrophy of sebaceous glands, hot potato voice, quinsy, peritonsillar abscess. Right. Moving down from the face beta, now if we take a look in the thorax. In the thorax, suppose this is the thorax, what we are seeing right in front of us. Now here in beta, this structure what you're seeing here, this is the trachea, which divides into the right and left bronchus. Normally, the brown structure what you're seeing, this is the esophagus. Normally the esophagus is something like this, right? During intrauterine life, sometimes what happens when the esophagus is developing like this, ideally both of them should join like this, and that is how the normal story should be. Actually beta, there is a septum between the trachea and the esophagus, which we call as the tracheoesophageal septum. Normally this septum is somewhat like this, and this septum keeps the trachea and the esophagus separate. But sometimes during intrauterine life, there is a possibility that this septum may deviate posteriorly, and if suppose the septum deviates posteriorly, then the esophagus, which was supposed to be developing like this, now what is going to happen? Because of this posterior deviation of the septum, these two ends of the esophagus will not be able to unite with each other. That means this part of the esophagus will be absent. There is no esophagus in this area. This is what we call as esophageal atrasia. A means absence, absence of some part of the esophagus. However, we can find n number of sequences in this. For example, we may find the upper end of the esophagus like this, lower end of the esophagus like this, or we may find the lower end of the esophagus joining with the trachea, abnormal relationship between two people, trachea esophagus fistula, tracheoesophageal fistula. This what you're seeing on the screen, this is actually the commonest thing what you see. The upper end of the esophagus is blind and the lower end of esophagus communicate with the trachea. This is the commonest type of esophageal atresia. Sometimes we may find something like this. Only the upper end of the esophagus is present. Sometimes we may find something like this. The upper end is communicating with the trachea and the lower esophagus may be blind. Or sometimes we have also seen the situations like this. If this is the trachea, then the esophagus may be like this. That means there is no absence of the esophagus, but esophagus is communicating with the trachea. That means there is no atresia here, just a fistula. This is called as H type. This is called as H type. H type, or you can say isolated tracheoesophageal fistula. No atresia, just an isolated tracheoesophageal fistula. So these can be the different types of esophageal atresias. Let us just focus on the commonest type of esophageal atresia. Commonest type where the upper end of the esophagus is blind and the lower end of the esophagus is communicating with the trachea. Let us just imagine this situation and try to understand what is going to happen. During intrauterine life, when the fetus is inside the mother's uterus, if the tracheoesophageal septum has deviated posteriorly, then this is the story what is developing in the baby. Now what is happening inside the fetus, beta? As you can see, there's a complete traffic jam here. So whatever saliva is forming in the baby's mouth, that saliva will not be able to go down into this esophagus. So all the saliva will get collected here, and this saliva may come out from the baby's mouth. More saliva coming out from the baby's mouth will add to the volume of amniotic fluid, and the amniotic fluid volume will increase, which we call as polyhydramnios. Polyhydramnios. So beta G, in esophageal atresia, you can find polyhydramnios in the mother during pregnancy. Now let us imagine the situation, how these babies present to us. This is a complete traffic jam situation, beta. Just imagine February 23. You are wearing that white coat and the stethoscope. Suppose you are posted in the labor room where deliveries are happening, and suddenly you take a delivery of a baby who is having esophageal atresia. As soon as you take the delivery of this baby, you keep the baby on the baby trolley, you are doing all the cleaning works and everything, you're looking at the baby and the baby might be looking at you, and suddenly you stroke the baby and the baby starts crying, wah, 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 something like this is going on. You clean the baby nicely, you look at the baby, you may ask the baby, are you comfortable? And the baby may tell you. That means you feel that everything is fine. Now you go and do some other work, or maybe you are writing down the notes for the delivery of this baby. The staff nurse of the labor room may go and visit this baby, and the staff nurse may find that there is something in this baby. Maybe after 5 minutes, 10 minutes, what is happening? Whatever saliva is there in the baby's mouth, that saliva is not coming down. So you may find that this baby is actually throwing the saliva from the mouth. There is frothing of saliva from the mouth. There is continuous pouring of saliva from the baby's mouth. And the staff nurse may look at the baby and the baby may look at the staff nurse. The staff nurse may ask and the baby may be. Now the staff nurse thinks that the doctor who took the delivery, he has not cleaned the baby nicely. So the staff nurse may come at you, hey doctor, you have not cleaned the baby nicely. See, the baby is throwing the saliva. You go towards the baby and you ask the baby, hey baby, what happened? The baby looks at you. You also feel that you might not have cleaned the baby nicely. You clean the baby again and then you go again and do your work. And again after 10-15 minutes, when the staff nurse goes towards the baby is again throwing the saliva. So now when the staff nurse calls you and you look at the baby, you start thinking, boss, the saliva is not going down. There is a complete traffic jam situation. That is why the saliva is continuously coming out. And you start suspecting there can be esophageal atresia. What you can do is you can immediately put some nasogastric tube or a feeding tube. If you put a nasogastric tube, will this nasogastric tube go into the stomach? No. So this nasogastric tube is going to get coiled in the upper esophagus. And that will give you an idea. There is a complete traffic jam. To confirm this, you can even take the X-ray in this baby. And if you take an X-ray in this baby, you may find something like this. See, this is the nasogastric tube which you have tried to pass. But this nasogastric tube has not gone down. There is coiling of the nasogastric tube in the upper esophagus. And this is what makes you gives you the help in making the diagnosis that yes, this is the case of esophageal atresia. Ideally, if there is no connection of the upper esophagus with the lower esophagus, that means whatever air the baby is swallowing in the upper esophagus, that should not go into the lower esophagus, that should not go into the stomach. So you should not be able to see the stomach or the intestines in this baby. But if you are able to see the stomach and intestines, despite esophageal atresia, it means that probably the lower esophagus is having a connection with the trachea. So whatever air is coming in the trachea, that is going through the tracheoesophageal fistula into the lower esophagus, into the stomach and intestines. That is why despite esophageal atresia, you are seeing gas in the stomach and the intestines. While if we compare this with another picture, now here in this picture, you are not seeing any gas in the stomach or the intestine, but you are seeing that there is a tube which is not going below. So this might be a case where there is esophageal atresia, so the tube is not going down and there may not be any fistula of the lower esophagus with the trachea. That is why you are not seeing any air in the stomach or the intestines. So this may help in trying to sort out what is the type of esophageal atresia. Majority of the times this is what we see. The upper esophagus is blind while the lower esophagus is connected to the trachea. So you are seeing the coiling of nasogastric tube in the upper esophagus and you are able to see the gas in the stomach or the intestines. Best investigation for this can be a CT scan. In the treatment for esophageal atresia, you are the surgeon, boss. You are the surgeon. Generally, the dictum in surgery, it is said that only those people choose surgery who don't have brains. Surgeons usually don't have brains. Because what a surgeon is supposed to do, he simply identifies where is the pathology, he simply chops that pathology out and he joins whatever normal part is remaining. That is what we are doing at all the places generally. especially in systemic surgery. So, my dear friends, if we have to make this baby absolutely normal, we know that we want that this upper esophagus should get connected to the lower esophagus and this fistula should be destroyed. There is no medicine which will be able to connect the upper esophagus with the lower esophagus. That means we have to do some or the other surgical intervention, right? On the first day of life or second day of life, you can do a thoracotomy, go inside the thorax, divide the fistula, repair the trachea, and connect the upper esophagus with the lower esophagus. Whenever we are connecting someone with someone in surgery, we use the term stomy or anastomosis. Here we are connecting the esophagus with the esophagus, so we call it esophagostomy. Esophagostomy, right? That should be the treatment. Sometimes we find some little different type of situations. For example, if suppose the two ends of the esophagus are far from each other, suppose this is the upper esophagus and here this is the lower esophagus. That means there is a big gap. There is a big gap between these two esophagus. If you do a thoracotomy at this stage, divide the fistula and try to join this esophagus with this esophagus, there is a big gap. You will not be able to join these two ends. If you try to force and do the anastomosis, the sutures will come under tension, and tension, the sutures will break. There is one saying in surgery that there should not be any kind of tension in surgery, neither while doing surgery nor while reading surgery. सर्जरी में कहावत है कि सर्जरी में कभी टेंशन नहीं होनी चाहिए, ना सर्जरी करते समय ना सर्जरी पढ़ते समय, because things have to be kept as simple as possible. Whenever any anastomosis is done under tension, जब भी कोई एनास्टोमोसिस टेंशन में की जाती है, टेंशन में टाके टूट जाते हैं. The sutures, they break whenever we are putting them under tension. So the very purpose of doing the anastomosis is defeated. Now, in these cases, if the two ends of esophagus are far from each other, what should be done? Ideally, we wait for some time, maybe 4 to 6 weeks time. Let the two ends of the esophagus grow. This is a small baby. Baby is in the growing age. So we just allow these two ends to grow and reassess after 4 to 6 weeks. If after 4 to 6 weeks we find that the two ends have grown and they have come quite close to each other, then we can join these two ends and do a esophagostomy. But if by chance after 4 to 6 weeks we come to know that the two ends have not still come close to each other, then we actually mobilize the stomach, and with the help of mobilization of stomach we try to bring this end up and then do the anastomosis. The question which is coming to my mind, that if the two ends of esophagus are far, we are first waiting for 4 to 6 weeks. If we are waiting for 4 to 6 weeks time, how will we provide nutrition to this baby? Can we give mother's milk from the mouth to this baby for 4 to 6 weeks? No, the milk is all going to come out. Which nutrition is better, enteral or parenteral? Yes, enteral nutrition is better. So, if we have to give enteral nutrition in this baby, the options which we can have, we can either put a tube into the esophagus or into the stomach or into the jejunum, and then we can give mother's milk from these tubes. This will be called as feeding esophagostomy. This will be called as feeding gastrostomy, and this will be called as feeding jejunostomy. Out of these three, which one would be better? If by chance you are giving mother's milk from this tube, there are high chances that this may go into the trachea and lead to pulmonary complications like pneumonia. The same story can happen with the stomach also. These secretions can also regurgitate and may go into the trachea. So a best option would be to put the tube into the jejunum, and then the chances of regurgitation will not be there. So when we are waiting in this baby for 4 to 6 weeks, we leave a tube into the jejunum and we give mother's milk through this feeding jejunostomy and let this baby survive for 4 to 6 weeks. I hope the concept is clear, Beta. So now let's take a look what all is written here in this esophageal atresia. Esophageal atresia is absence of some part of the esophagus. Absence of some part of the esophagus. This is due to posterior deviation of tracheoesophageal septum. This TE beta is tracheoesophageal. Most common type of esophageal atresia is a type C, and type C is this what you are seeing here. This is the esophagus, this is the trachea. Upper esophagus is blind, while the lower esophagus communicate. Upper esophagus is blind, while the lower esophagus communicate with trachea. This is the commonest type of esophageal atresia. There is another type which is a H type. This is an isolated tracheoesophageal fistula where there is an abnormal relationship between the trachea and the esophagus. There is no atresia of the esophagus as such. Many a times we have seen that this esophageal atresia may be associated with other congenital anomalies also, which are remembered by the mnemonic VACTERL, wherein V stands for vertebral, A for anorectal, C for cardiac, TE for tracheoesophageal fistula, R for renal, and L for limb defects. VACTERL: vertebral, anorectal, cardiac, tracheoesophageal fistula, renal, and limb defects. Suppose we discuss the commonest type of esophageal atresia in detail, as we have been discussing during pregnancy. When the fetus is inside the mother's uterus, since there is a complete traffic jam in the upper esophagus, the saliva is not going down. The saliva is continuously coming out of the baby's mouth and will be adding on to volume of amniotic fluid, that is polyhydramnios. So we find polyhydramnios in pregnancy in esophageal atresia. This is usually the earliest finding. during pregnancy. However, how this baby actually presents to us most commonly at birth. Now, please do remember, beta, there will be anomalies which are presenting immediately after birth. There are anomalies which are presenting within few hours after birth. There are anomalies which are presenting 7 days after birth, anomalies presenting 17 days after birth, and so on. Right? So, MCQ people also are focusing on these areas. Here we can understand if there is a complete traffic jam in the upper esophagus, nothing is going down, the story is going to present immediately after birth. So at birth, what we are finding is continuous pouring of saliva. From the baby's mouth. Continuous pouring of saliva from the baby's mouth. There is risk of regurgitation, aspiration, and pulmonary complications. Initial evaluation or initial bedside test, what you can do is, you can try passing a nasogastric tube. Tell me, beta, will the nasogastric tube go into the stomach? No. Failure to pass the nasogastric tube beyond 10 centimeters. Failure to pass the nasogastric tube beyond 10 centimeters makes us suspect that yes, there is esophageal atresia. And on initial investigation, we do a chest X-ray wherein we can find coiling of nasogastric tube in the upper esophagus. If we find distended stomach with gas, this indicates tracheoesophageal fistula. This indicates tracheoesophageal fistula. Best investigation or investigation of choice would be CT scan. Best investigation would be CT scan. In the treatment, obviously we have to do surgical correction. अच्छा बेटा, कौन सी एज पे हम करेंगे सर्जरी? Should we do this operation at birth or should we do this operation at 50 years of age? Good, very good. That means you are still awake, right? Okay, so we are going to do surgical correction on day 1 of life, or sometimes maybe day 1 or day 2 after birth. Acha ji, what surgical correction you have to do, beta? You have to divide the fistula, division of fistula, and esophagostomy. Obviously, for doing this, we have to do a thoracotomy. We have to open the thorax and then we can do this surgery. Acha beta, another thing I would like to remind you, whenever we are doing any thoracic surgeries, Suppose we are doing a left-sided thoracotomy for this treatment, then you know that your thorax, inside you have got air balloons, lungs, and these are occupying the entire space of your thoracic cavity. So if you have to do this surgery and there is an air balloon occupying the entire space, you will not be able to do this surgery. You will not be able to see anything inside. That is why in thoracic surgeries, we use a special type of endotracheal tube which has got two lumen. So this two lumen endotracheal tube, one is going on this side, another is going on this side. If you are operating on this side, we clamp this side so that no air goes into this side lung and this gubbara collapses. This lung collapses. As the lung collapses, then you will get a wide view inside the thoracic cavity. You will get a nice space inside the thoracic cavity and you can perform whatever surgery you want. So, in all thoracic surgeries, a special anesthesia using a special endotracheal tube which has got two lumen, double lumen endotracheal tube is used. Right. If suppose the examiner gives you a situation, the doctor, if suppose the two ends of esophagus are far from each other, then you wait for 4 to 6 weeks time. Allow the two ends of esophagus to grow, and during this waiting period, to keep the baby alive for nutrition, you can put a tube into the jejunum, that is feeding jejunostomy. After 4 to 6 weeks, you reassess the two ends of esophagus. If the two ends of esophagus have come close to each other, then you can do esophagostomy. But if they still remain far from each other, then we do esophageal reconstruction. Esophageal reconstruction. And for this we have to mobilize the stomach for making the reconstruction possible. This image what you are seeing beta, herein, this is the upper esophagus, this is the lower esophagus, and there is a fistula here. This is just to demonstrate that which type of nutrition we are giving. If we are putting a tube into the stomach, that is feeding gastrostomy, versus we are putting a tube into the jejunum feeding jejunostomy. If we are doing a feeding gastrostomy, the feeding contents of the food material, the milk, can regurgitate and go into the trachea and can lead to pulmonary complications. So instead of doing a feeding gastrostomy, we prefer doing a feeding jejunostomy, so the chances of regurgitation and pulmonary complications are not there. Right? I hope beta, this esophageal atresia is nicely understood. Atresia. A means absence. Some part of the esophagus is absent. Right? Just look at me on the screen so that we can quickly just revise this important entity. Right, beta. So esophageal atresia. Just try to correlate the words so that you don't have to memorize too many things. A means absence. So this is what we are talking about, absence of some part of the esophagus. Most often it is due to posterior deviation of the tracheoesophageal septum. Most commonly the upper esophagus is blind and the lower esophagus connects with the trachea, which is a tracheoesophageal fistula. We can also find an isolated tracheoesophageal fistula where there is no atresia but just abnormal relation of the esophagus with the trachea, that is a H type of tracheoesophageal fistula. This esophageal atresia can be associated with congenital anomalies in other systems like VACTERL, V vertebral, A anorectal, C cardiac, T tracheoesophageal, R renal, and L limb defects. Now, if suppose this fetus during pregnancy is having esophageal atresia, the saliva in the fetal mouth will not be going down into the stomach. All the saliva will be coming out from the fetal mouth, increasing the volume of amniotic fluid. Polyhydramnios will be an early sign which we can notice in pregnancy in esophageal atresia. How these babies present to us immediately after birth, because of complete traffic jam of the esophagus, there will be continuous pouring of saliva from the baby's mouth. There will be chances of regurgitation, aspiration, and pulmonary complications. We can do a simple bedside test, pass a nasogastric tube. If there is esophageal atresia, we are not able to pass this tube usually beyond 10 centimeters. Initial investigation, what we can do is chest x-ray. Therein, coiling of nasogastric tube in the upper esophagus gives us an idea about esophageal atresia. If we find the stomach or the intestines distended with gas, that means the lower esophagus is having a fistula with the trachea. To confirm our diagnosis even better, we can do a CT scan, and the treatment for this pathology should be surgery. On day 1 or day 2 of life, we open the thorax. We do a single lung ventilation by using a double lumen endotracheal tube. We divide the fistula and join the two ends of esophagus, that is esophago-esophagostomy or esophago-esophageal anastomosis. If by chance, before the operation, we come to know that the two ends of esophagus are far from each other, then there is no point in doing a thoracotomy and trying to do a esophago-esophageal anastomosis under tension. It is better to wait for 4 to 6 weeks' time, let the two ends of esophagus grow, and reassess after 4 to 6 weeks. During this 4 to 6 weeks, we put a tube into the jejunum for feeding purpose, feeding jejunostomy. After 4 to 6 weeks, when we reassess, if the two ends of esophagus have come close to each other, we do a esophago-esophagostomy. But if they still remain far from each other, we mobilize the stomach and do a esophageal reconstruction. Right. Is that clear, beta? Good. There is another hello. When did this happen? I hope it's fine now. Okay, so it went just now. That means the revision part was okay, beta. Shinu, can you just mention Ashok, beta, anyone? No, beta. No, I know Shinu. Shinu, just let me know if we were able to revise that esophageal atresia without the workbook. Okay, Shinu. Thank you, beta. Thank you so much. Fine. So probably I might have just put this on mute. Okay. Right. So we let's take a look at this dysphagia lusoria. Now, what is dysphagia lusoria, beta? Dysphagia means difficulty in swallowing, and lusoria term is a specific term which is used for aberrant right subclavian artery. Okay. Now here in this image, if we just try to understand this structure, beta, what you are seeing here, this is the arch of aorta. This structure, what you're seeing here, beta, this is the arch of aorta. And from here, we know that there are major vessels which are originating. Like here we can see, this is the left subclavian artery. This is the right subclavian artery, right? This structure, beta, what you're seeing, this is the trachea. And this structure, what you're seeing here, this is the esophagus. This is the esophagus. Sometimes, beta, what happens, if there is aberrant right subclavian artery, ideally, the subclavian artery should have been going like this, and there should have been no compression on the esophagus. But if suppose the subclavian artery is going like this, it may start putting pressure on the esophagus. So the esophagus is compressed by this aberrant right subclavian artery. This is what we call as dysphagia lusoria. And we can understand, beta, that if somebody is pressing the esophagus, then how will the patient be able to swallow the food nicely? अगर हमारे फूड पाइप को किसी ने दबा दिया है, तो जब हम रसगुल्ला खाएंगे तो क्या ये रसगुल्ला आसानी से जा पाएगा? नहीं जा पाएगा, right? So basically, compression of the esophagus by aberrant right subclavian artery, that is dysphagia lusoria. Sometimes, beta, this compression of the esophagus can be by a double aortic arch. Maybe double aortic arches are present, they may compress the esophagus. Or sometimes instead of a left aortic arch, there may be a right aortic arch which may be putting compression on the esophagus. Any compression on the esophagus will cause dysphagia. But dysphagia lusoria term is a specific term when aberrant right subclavian artery is compressing the esophagus, right? So if this is the vessel which is compressing the esophagus, that is what we call as dysphagia lusoria. Right. So dysphagia lusoria is compression of esophagus by aberrant right subclavian artery. This is usually a single liner question, beta, and you get 1 out of 1. Dysphagia lusoria is compression of the esophagus by aberrant right subclavian artery. However, compression of the esophagus can be seen by double aortic arch or a right aortic arch also, right? Fine. Now from the thorax, if we move down into the abdomen, and in the abdomen, if we take a look at the indexing, beta, what we thought that in the abdomen will be going in a sequence. First the epigastric stories, then the right hypochondrial, then the flank stories, then the iliac fossa stories, then the hypogastric stories, then the urethral and the scrotal stories. So here, let us first talk about the stomach duodenum scenarios. In the stomach duodenal scenarios, beta, there is one thing called as duodenal atresia. Duodenal atresia. Just like esophageal atresia, beta, that was absence of some part of the esophagus. Duodenal atresia will be absence of some part of the duodenum. Now, why some part of the duodenum can be absent, beta? We know that in GIT, suppose I say that this is the esophagus. Suppose this is the esophagus. This is the stomach. and here lies the duodenum. This what I have drawn just now, this is the foregut. Then from here, midgut starts. That is the third part of duodenum, fourth part of duodenum, jejunum, ileum, and so on. And then this ileum joins with the cecum. There is ascending colon, there is transverse colon, there is descending colon, there is sigmoid colon, then there is rectum, and then there is anal canal. Let me just move myself to the side. Right. Okay. So this is the general story what we are seeing here, beta. The esophagus, stomach, duodenum, jejunum, ileum, cecum, ascending, transverse, descending, sigmoid, rectum, and the anal canal. Now, I would like to tell you, beta, this story what we are seeing here, this is the foregut story. This is what we call as the foregut. And here, this what you are seeing here, this is the midgut story. All this is midgut. And here what you are seeing, this is the hindgut story. Right? That means here, this is the junction of foregut and midgut, and here would be the junction of midgut and hindgut. So foregut is having this esophagus, stomach, and the first, second part of duodenum. Midgut is the third, fourth part of duodenum, jejunum, ileum, then there is cecum, then there is ascending, and the proximal 2/3 of transverse colon. While hindgut is the distal 1/3 of transverse colon, descending colon, sigmoid colon, and the rectum down. Sometimes what happens, beta, we should also know here that regarding the blood supply of GIT, foregut is supplied by celiac trunk, midgut by superior mesenteric artery, hindgut by inferior mesenteric artery. That means, beta, we should be very clear here that if this all blue color is the foregut, so blue color is supplied by celiac trunk, the entire purple color is supplied by the superior mesenteric artery, and the entire hindgut is supplied by the inferior mesenteric artery. Right? Okay. Foregut, midgut, and hindgut. Right. Sometimes what happens, beta, during intrauterine life, the foregut has to unite with the midgut. But if the foregut does not unite with the midgut, then this part of the duodenum will be absent. And that is what we call as duodenal atresia. That is what we call as duodenal atresia. Right? What is going to happen? If suppose I say that this is the esophagus, this is the stomach, and here this is the duodenum, we should know that where the bile duct is opening, where the pancreatic duct is opening. So beta, if you just look at this particular picture, this dark brown what you're seeing, this is the foregut. The common bile duct and the pancreatic duct, they are opening into this foregut area, right? Just at the terminal part of the foregut. And here what we are trying to say, that foregut has not united with the midgut. That means, suppose this is the story here. That means here this part of the duodenum is absent. There is a complete traffic jam situation. This is the most common cause of intestinal obstruction in a newborn baby. अब ये बताओ बेटा, just tell me one thing. If there is a complete traffic jam in the duodenum here, at what age this baby will present to you? Will the baby present at birth, or the baby will present at 1 year of age or 50 years of age? ये समस्या कब सामने आएगी? अपने बर्थ पे आएगी, 1 साल पे आएगी, या 50 साल पे आएगी? Obviously, there is a complete traffic jam, so the story has to present at birth. Now, beta, esophageal atresia will present earlier than duodenal atresia. Esophageal atresia was presenting immediately after birth. But duodenal atresia babies, what will happen, beta? When this baby takes the feed, जब ये छोटा सा बेबी माँ बच्चे को दूध पिला देती है, now whatever is going inside, this is not going to go down. This is going to get arrested here. That means pressure in this area will increase, because of which the intragastric pressure will increase, and because of high intragastric pressure, the gastric muscles may contract forcefully and they will try to throw the story out. So when the story is thrown out, there is vomiting. The MCQ people want to know whether this vomiting will have bile staining or not. Yes, there is a traffic jam distal to the opening of bile duct. So here you will definitely having the biliary secretions. So when the baby will be vomiting, this vomiting will be bilious or bile stained vomiting, right? Usually within 6 hours after birth. We can take the help of X-rays also, but before that, let us first write what is written here. Duodenal atresia is absence of some part of the duodenum. This is due to failure of fusion of foregut with midgut. How the baby presents to us, Peter? There is bilious vomiting. Within few hours after birth. Esophageal atresia was presenting with continuous pouring of saliva from the mouth at birth, immediately after birth. Duodenal atresia is presenting with bilious vomiting within few hours after birth. Okay. This duodenal atresia is the most common cause of intestinal obstruction in a newborn baby. Overall, the commonest cause of intestinal obstruction, if no age is specified, it is postoperative adhesions. What is this post-op adhesions? Suppose you are the surgeon and you are doing a laparotomy. When you are doing a laparotomy, you are going inside the abdomen, you are handling the intestines. Many times, because of handling of the intestines, unknowingly we cause some injury to the outer layer of the intestine. When the laparotomy is over, patient is shifted out, maybe after a few years of this surgery. Because of some injuries which have been caused on the outer surface of the intestine, there would be inflammation, healing, fibrosis, and maybe few loops of intestine may adhere with each other. I repeat this in Hindi, beta. Post-op adhesions. अगर मान लीजिए आपने कोई लेप्रोटमी या कोई ऑपरेशन इस तरह का किया है जिसमें पेट खोला गया हो, और आपने इंटेस्टाइन्स को अपने हाथों से हैंडल किया है, तो अननोइंगली हम इंटेस्टाइन की बाहरी दीवार पे कुछ चोट पहुंचाते हैं, जो धीरे धीरे हीलिंग होके, फाइब्रोसिस होके कुछ सालों में, हो सकता है 5 साल, हो सकता है 10 साल, 15 साल में, वो फाइब्रोसिस की वजह से जो आते हैं उनके लूप्स आपस में एक दूसरे से चिपक जाते हैं, उसको अपन बोलते हैं पोस्ट ऑप एडिशंस. दैट इज द कॉमनेस्ट कॉज ऑफ इंटेस्टाइनल ऑब्स्ट्रक्शन ओवरऑल. But if they ask you intestinal obstruction in a newborn baby, then it is duodenal atresia. Duodenal atresia is also the most common GI anomaly associated with Down syndrome. Most common GI anomaly associated with Down's is duodenal atresia. Now let us try to see that what we can find on X-ray. Right? Suppose this is the esophagus, this is the stomach, this is the duodenum, and this is the jejunum. The same story, suppose. If I say that there is a traffic jam at the pyloric level, बेटा स्टमक के जो पार्ट्स होते हैं ना, तो स्टमक में ये जो ऊपर वाला पार्ट है इसको अपन कार्डिया बोलते हैं, ये जो उठा हुआ हिस्सा है इसको अपन फंडस बोलते हैं, बाकी ये जो हिस्सा है इसको अपन बॉडी बोलते हैं, इस हिस्से को अपन प्री पाइलोरिक या एंट्रम बोलते हैं, और इस हिस्से को अपन पाइलोरस बोलते हैं. नाउ वी आर जस्ट ट्राइंग टू इमेजिन the different clinical scenarios, or what I'll do is I'll just remove this and let us try to create a totally new impression in our mind. Right. Suppose this is the esophagus, this is the stomach, this is the duodenum, another picture, now if I say there is a traffic jam, suppose at the level of pylorus, here there is obstruction, what will happen, beta? We all can understand nicely that because of the traffic jam, the story will not be able to move beyond this. Proximal to the traffic jam, the story will get dilated. That means all this area is going to get dilated. And distal to this, the area will get collapsed. Now, when this is getting dilated, beta, definitely the intragastric pressure will increase, vomiting will be there. Tell me, if I say that bile duct opens here in this proximal part, and there is a traffic jam which is seen at this area, what is going to come out in this baby? Whatever is there inside the stomach, that is going to come out. Is there any bile inside the stomach here? No. Bile is here. So bile can only come up to this place. But if there is a traffic jam here, then only this story is going to come out in vomiting. So if there is a pyloric obstruction, the vomiting will not have bile in it. So that will be a non-bilious vomiting, right? Okay. Now, if suppose we are taking a X-ray, we know that what is there in our GIT. We have got a lot of air in our GIT, which we can easily understand. हम हवा यहाँ से पीते हैं और वहाँ से निकालते हैं. We swallow the air from here and we pass it out through the anus, right? So that means our entire GIT is full of air, plus whatever we eat, that is there. The digestive juices are there. That means liquid contents, everything is there. If I say that there is a pyloric obstruction, what is going to happen? Obviously, the liquid here is going to settle down and the air inside the stomach will rise up. The air is going to rise up. Now when you take the X-ray, you can see this air fluid level on X-ray. Can you appreciate this? On X-ray we see air as black, na beta? Pneumothorax, if you remember, right? So we can see this air fluid level. How many air fluid levels we are able to see if there is an obstruction in the pylorus? 1. So in pyloric obstructions, we see single fluid level, 1 air fluid level, which is in fact normal also. In your stomach also, beta, the fundus is lying like this. So air is trapped beneath the fundus. So if we take a X-ray in you right now, we'll be able to see that air fluid level in your abdomen, in the left upper abdomen on abdominal X-ray, right? So that is normal. But yes, in pyloric obstructions, we can understand that the stomach will be distended like anything. The fluid is going to settle down, the air is going to rise up, and when we take the X-ray, we can see 1 air fluid level, right? Now, if suppose we try to create something different, if I say, beta, that there is a traffic jam in the duodenum. Suppose I say we are talking about duodenal atresia. That is, foregut has not united with the midgut. There's a traffic jam. What will happen? The basic concept what we know, beta, proximal to the traffic jam, the story gets dilated, and distal to the traffic jam, the story gets collapsed. That means in duodenal atresia, this is what we are going to see. Herein, why I have drawn something like this? Why I have not drawn this whole unit as single dilatation? Why I have not drawn this like this? There is a logic here. Actually, in the distal part of the stomach, there is a sphincter. This is the pyloric sphincter, beta. And the sphincter cannot dilate. That is the reason why this part of the stomach, that is the pylorus, cannot dilate despite an obstruction here. That is the reason why in duodenal obstructions, this part of the duodenum dilates separately and this part of the stomach dilates separately. If this is the case, then what is going to happen, beta? Fluid is going to settle down like this. Fluid is going to settle down like this, and the air is going to rise up. Air is going to rise up like this. Air is going to rise up like this. That means now what I'm able to appreciate, I'm able to see 1 air fluid level here. I'm able to see another air fluid level here. 1 and 2. That means now if I take the X-ray, I'll be seeing this air also. I'll be seeing this air also. That means in duodenal obstructions, you will find 2 air bubbles. Pyloric obstruction, beta, ध्यान से देखिएगा. If there is a traffic jam at the pylorus, only the stomach was dilating, so single bubble. Duodenal obstructions, beta. The pylorus is not able to dilate, so duodenum is dilating separately, stomach is dilating separately, so you are seeing two air bubbles. Now, if you keep on applying this concept, beta, herein, suppose I say this is the stomach, this is the duodenum, and this is the jejunum, and I say there is a traffic jam in the jejunum. Suppose we create a traffic jam in the jejunum here. What will happen? Ideally, all the proximal people should dilate. Ideally, what should happen? Everything above should dilate as one unit, right? Right. But what happens, beta? God has given a ligament of Treats in this area. At the duodenojejunal junction, there is a ligament of Treats, because of which this duodenojejunal junction cannot dilate. So now what is going to happen? This part is going to dilate separately. Then this part is going to dilate separately. This part is going to dilate separately. Okay, so if it is not properly seen, I'll use another color beta here. Suppose I say that this jejunum will dilate separately, this duodenum is going to dilate separately, and the stomach is going to dilate separately. We know that this pylorus cannot dilate. We know the duodenojejunal junction cannot dilate. That is why we are seeing separate stomach, separate duodenum, and separate jejunum. And we also know that in all these areas, beta, the fluid will settle down and the air is going to rise up. Now when you take the X-ray, beta, you can see nicely, you will see a air fluid level here, you will see a air fluid level here, you will see a air fluid level here. So how many bubbles we are able to see now? 1, 2, 3. That means in jejunal obstruction, we find 3 bubbles, triple bubble. Now if we go into the intestines, the ileum. In ileum, what is going to happen? Like what we are seeing in this. This is the esophagus, this is the stomach, suppose. Then this is the duodenum, this is the jejunum. Suppose all this what we are seeing, this is the ileum. And suppose this is the ileum. Right? Now, if I say there is a traffic jam in the ileum here, अगर रास्ते में यहाँ पे रुकावट है, so what will happen? The entire proximal story is going to get dilated. That means all this story is going to get dilated. And since the small intestine is 6 meters and it is lying as loops, so this will appear as one loop, this will appear as one loop, there may be another loop here. The jejunum is like this, the duodenum is like this, the stomach will be like this. And in each loop, we can understand that fluid is going to settle down, air is going to rise up. So now when we take the X-ray, what we'll see, there would be air here, 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 there would be air here. That means if we take a look at the fluid levels, it is not 1, 2, or 3. There are multiple air fluid levels, what we can see here. Multiple fluid levels, what we can see here. So if we are talking about small intestinal obstruction, we find multiple air bubbles. The only thing is, in small intestinal obstruction, these multiple bubbles are located in the central part of abdomen, while if it is a large intestinal obstruction, the fluid levels are located in the peripheral part of abdomen. If we try to take a look at these x-rays, beta, in this particular x-ray, now this is a hot x-ray what we are seeing here. In this abdomen, you are seeing a huge air bubble here and you are seeing another air bubble here. So how many bubbles you are seeing, beta? 1, 2. Double bubble. Double bubble is seen in duodenal. D for D. Double duodenal. Right? In duodenal atrasias or any other reason for duodenal obstruction, we will find double bubble sign. This X-ray, here you can see, beta, there are multiple fluid levels what you are seeing. There are multiple fluid levels what you are seeing, and these fluid levels, beta, they are confined in the central part of abdomen. This is a case of small intestinal obstruction. Another picture, beta. If you see in this picture, you see again multiple air fluid levels. But now these multiple air fluid levels, they are located in the peripheral part of the abdomen. So this should be a case of large intestinal obstruction, right? Once again, let us see this, beta. This where you are seeing two bubbles, double bubble, duodenal obstruction. This you are seeing multiple bubbles in the center of the abdomen. This is small intestinal obstruction. This what you are seeing, multiple bubbles in the periphery of the abdomen. This is a large intestinal obstruction. बात समझ आई बेटा? I hope the concept is clear. Right. So now if we take a look, beta, this single bubble. अच्छा बेटा जल्दी बताओ, this SBS, this is actually single bubble sign. Single bubble sign. On X-ray, single bubble किस में मिल रहा है बेटा? Pyloric obstruction. Double bubble you are seeing in duodenal obstruction. Triple bubble, this T is triple. This is seen in jejunal obstruction. This M is multiple. So multiple bubble sign, if it is located in the center of the abdomen, this is small intestinal obstruction. And multiple bubbles in the peripheral part of the abdomen, this is large intestinal obstruction. Right. Okay, बेटा, एक बार इसको करें बेटा. Right? Okay, I'm just अच्छा पहले लिख लो. First complete this. चलिए. So we are actually discussing about duodenal atrasia, and duodenal atrasia में we just saw that we will find double bubble sign on X-ray. You can also mention, beta, what can be the various pathologies the examiner may give you. For pyloric obstruction, they may give you a pathology which is congenital or infantile hypertrophic pyloric stenosis. Congenital or infantile hypertrophic pyloric stenosis. So pyloric stenosis we can very well understand. Pyloric stenosis we can understand, beta. There would be a single bubble. Duodenal obstruction stories, how he can cook for you. He may give you duodenal atrasia, or there is another condition which we are going to read just now, annular pancreas. Annular pancreas. Jejunal obstruction story. he may give you something like jejunal atresia. Right? So this is how he can give you different stories, and he may ask you, ki bhaiya, you are doing an X-ray, what will you see? So if the concepts are absolutely clear in your mind, then you will not find any challenge. Right. Single bubble, pylorus, double duodenal, triple jejunal, multiple central, small intestine, multiple peripheral, large intestine. Single pylorus, double duodenal, triple jejunal, multiple central, small intestine, multiple peripheral, large intestine. Let us just remove this and try to do this, beta. Can you speak out with me? Can you speak out from your vocal cords, beta? Yes. Single, double, triple, multiple central, multiple peripheral. थोड़ा फास्ट करेंगे बेटा. सिंगल, डबल, ट्रिपल, मल्टीपल सेंट्रल, मल्टीपल पेरिफेरल, सिंगल, 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 डबल, 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 ट्रिपल, 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 मल्टीपल सेंट्रल, मल्टीपल सेंट्रल, मल्टीपल पेरिफेरल, multiple peripheral, single, double, triple, multiple central, multiple peripheral, multiple central, triple, double, single. Wonderful. Great. Right, beta. Now, what should be the treatment for this duodenal atresia, beta? Again, the story is very simple. What was the problem here? The two ends of the duodenum, there was absence of some part of the duodenum here, beta. So what we can do is, we can do the surgery, laparotomy, and we can join this duodenum with this duodenum. This will be called as duodenostomy. Duodenostomy. So the treatment of choice, what we are doing here is duodenostomy. Sometimes we can come across a situation, beta, like here, we have tried to explain that situation, that suppose this is the first and second part of duodenum, and this is the third, fourth part of duodenum. Another picture, something like this. The pinky thing, beta, what is shown here, it is just showing the gap. Here you can see there is a big gap. If the two ends are close to each other, we can do a duodenostomy. But if there is a big gap and the two ends are far from each other, if this end and this end, they have a big distance, then you will not be able to join this duodenum with this duodenum. Also, beta, we should know that it is very difficult to mobilize the duodenum because here actually lies the pancreas. Pancreas is lying in the C loop of the duodenum. So it is not easy to mobilize this duodenum because everything is fixed. So duodenum is not something which we can easily move or mobilize. That means if there is a big gap, if I say that there is a big gap between the two here, now you will not be able to join this duodenum with this duodenum. In such circumstances, beta, we pick up the innocent guy of GIT, that is the jejunum. We know that the jejunum and ileum, they are 6 meters long and they are lying free in our abdomen. If you are lying, suppose if you are taking this posture, then this intestine will fall like this. If you are taking this posture, then the intestine will fall like this, right? So this small intestine is something which is freely mobile. So what we do is we take the help of jejunum. We can chop or we can transect the jejunum at this area, and then we lift this part and bring this part here and connect this jejunum here. That means you're joining this with this, right? This part you have removed and you have just connected it here. So all this is actually connected here, right? So now everything will be moving here. That means now you are connecting the duodenum with the jejunum. Duodenum with the jejunum. Here you are connecting duodenum with the duodenum. Ideally, the treatment of choice should be duodenostomy. But if there is a big gap between the two ends of duodenum, then we can just request the jejunum and bring it to the duodenum and do a duodenojejunectomy. So alternative treatment, beta, what we can do here is a duodenojejunectomy. Duodenojejunectomy. But the treatment of choice will remain duodenostomy. DD, DJ. DJ wale babu. Right. Now another condition is annular pancreas, beta. Annular pancreas. Let me show you the picture. Here what you're seeing, beta, this is the pancreas what we are seeing here. But here we are finding that there is some abnormality. There is a ring of pancreatic tissue which is surrounding the duodenum, and ring-like is what we call as annular. This is what is a annular pancreas. This image also has been asked in our exams earlier. I hope you will be able to identify, beta. Right. Now, as you can see, this annular pancreas may also be causing duodenal obstruction. So the same story can present to us. The proximal pupil will dilate and the patient can present with bilious vomiting. When we take the X-ray in these babies, beta, We know ideally all this story should dilate as a one unit, but there is a pyloric sphincter here which cannot dilate. So duodenum will dilate separately and stomach will dilate separately. How many bubbles you will see, beta? Two bubbles. In the treatment, since we cannot separate this pancreas from the duodenum because it is fused with the duodenum, पैनक्रियास को ड्यूडनम से कोई जुदा नहीं कर सकता, दोनों के बीच में बड़ा गहरा रिश्ता होता है. If you cannot remove this ring of pancreas and you have to restore the continuity of the duodenum, you can chop the duodenum here, you can chop the duodenum here, bring this duodenum in front of the ring and then join this duodenum with this duodenum. Duodenostomy. For example, if suppose I take the example of something like this. Now, this water bottle, what you're seeing right now, beta, suppose this is the water bottle here, and here I say that there is a ring of pancreatic tissue which is pressing the duodenum. So what we can do, yeah, now suppose this is the ring of pancreatic tissue here, right? If you cannot separate this from the bottle, then you can transect the bottle from here, bring this end of the bottle here, this end of the bottle here, and join the two ends. That is what we are doing in duodenostomy. Sometimes what happens, beta, if suppose the ring is quite wide, if this annular pancreas is like this, or maybe annular pancreas can be somewhat like this. Now, if the story is like this, and you transect the duodenum here and here, you will not be able to join this duodenum with this duodenum. In these cases, you request the innocent guy, jejunum, and you can connect this duodenum with the jejunum. That means, usually, the treatment of annular pancreas is something duodenostomy. But if this ring is wide, then we can do duodenojejunectomy. So the same story what we are doing in duodenal atresia applies for annular pancreas also. Right. Okay. So annular pancreas, beta, this is just a ring of pancreatic tissue which actually surrounds the duodenum. On X-ray, we see a double bubble sign, and treatment of choice is duodenojejunectomy. Alternative treatment is duodenojejunectomy. So this is all about the duodenal story. Now we'll take a break here, beta, and we'll be back. At 5:50 p.m. Right? And then we'll be discussing about the pyloric stenosis, the pylorus story, and then we'll be moving away from the epigastrium into the right hypochondrium. Right? Thank you very much. Thank you for your patience, beta. Hello. Right, beta. So now let's take a look further in the epigastric story. Another thing which is closely related here is the hypertrophic pyloric stenosis. That is a congenital or infantile hypertrophic pyloric stenosis. As we are moving gradually, we'll try to imbibe as many concepts as possible so that our life becomes easier and easier as we go down. This is congenital hypertrophy of the pyloric musculature. Basically what happens, as we were talking about, that suppose this is the esophagus and this is the stomach, then the pylorus is actually a sphincter. So because of the sphincter, suppose I say that this is the pyloric muscle. Now sometimes if this pyloric muscle gets hypertrophied, then it is definitely going to create a traffic jam type of situation. Normally, suppose I say that the lumen normally, suppose this is the pylorus like this. That means the lumen what you are seeing here, this is the lumen. But sometimes what can happen, for reasons not very well understood, this pyloric musculature can get thickened. And if this pyloric musculature gets thickened, then we can understand what is going to happen to the lumen here. Please remember, beta, this is not a atresia. This is not a absence, but it is just a stenosis. It is just a narrowing of the lumen. It will act as a traffic jam situation. Usually it has been observed that it takes some time for these pyloric muscles to hypertrophy. So this baby actually presents with this distended stomach, non-bilious vomiting after second week of life, usually between second to sixth week of life, usually at around 17 days of life. So that is the clinical presentation what you may be getting in your exams, right? Esophageal atresia, duodenal atresia, they were presenting immediately after birth. Esophageal atresia just after birth, while duodenal atresia was presenting within few hours after birth. But this hypertrophic pyloric stenosis will be presenting in the third week of life, after second week, second to sixth week. Okay. Usually, the firstborn male child is what has been observed to be affected for reasons not known. The incidence can be 2 to 3 or 3 to 4 per thousand live births. These babies can present with a lump in the epigastric region, which is usually an olive lump in the epigastrium. For example, if you just try to correlate with one of the images here, this is the 15-day-old baby what you're seeing here. And because of thickened pyloric musculature, sometimes this baby can present with a olive-shaped lump. There's a olive-shaped lump here in the epigastrium. And this is what is olive. This is because of thickening of the pyloric muscles. For example, in this particular baby, if we try to see, this is the olive lump, suppose here. This part what you are seeing, you would be able to appreciate that this part looks to be a bit distended. This is the stomach which is distended. So when we are examining this baby, we can feel this hypertrophied pyloric musculature as an olive lump. We can see the distended stomach. And now if you give some feed to the baby, maybe mother's milk to the baby, you will see vigorous peristaltic movements in the stomach. The peristalsis in the stomach will try to force this mother's milk to go down. And you can see vigorous contractions of the stomach here, moving from left side to the right side. But because of a traffic jam situation here, The milk is not able to move down, so the intragastric pressure is increasing, and then the stomach will contract forcefully, and this is going to throw the gastric contents out. This will be bilious or non-bilious, beta? Very good, non-bilious. Now, when huge amount of gastric contents are moving out, you know, beta, what is there inside your stomach? You have got huge amount of acid inside your stomach, right? So if there is huge amount of acid inside your stomach, huge amount of acid, this acid is going to come out in vomiting. That means acid will be getting lost from the body. So relatively, alkali will increase. And MCQ people keep on asking, tell me beta, in pyloric stenosis, what will be the metabolic abnormality, whether it will be metabolic acidosis or alkalosis? So what is the answer beta? It will be metabolic alkalosis. Very good. अगर बॉडी में से एसिड बाहर निकल रहा है तो अंदर एल्कलोसिस हो रही है. अच्छा बेटा, in this acid actually if we take a look, this is HCl, है ना, HCl है. So H ion is also getting lost and chloride is also getting lost. If chloride is getting lost, then what will happen to chloride levels in the blood? जो बच्चे का blood है उसमें chloride का क्या होगा? If chloride is getting lost, so the chloride is going to go down, right? And if the chloride is going to go down, you will call it as hypochloremia or hyperchloremia. Hypochloremia, right? Fine. Now when this metabolic alkalosis is happening inside the baby, just imagine a 15, 17, 20 days old baby who is having metabolic alkalosis inside. The kidneys of this baby should try to throw the alkali out in urine so that the normal homeostasis is maintained inside the body. Initially, the urine of this baby would be alkaline. But another important thing to understand here, beta, because of this pyloric stenosis, there is persistent vomiting, because of which the baby is getting dehydrated. बच्चे के अंदर पानी की कमी भी हो रही है. Because of this dehydration, the body will try to conserve water inside. So the hormones like antidiuretic hormone, ADH, aldosterone, they will be stimulated. And these ADH, aldosterone, they will be acting on the baby's kidney, and they want that the kidneys should conserve water. Kidneys should not throw out too much of water. That means when water is getting absorbed from the kidneys, sodium is also getting absorbed. When sodium is getting absorbed by the kidneys, then potassium and H ions are excreted by the kidneys. I repeat this in Hindi beta. ये जो छोटा सा बच्चा है, 20 दिन का बच्चा है, लगातार उल्टियां कर रहा है. अब उल्टी करने से इसके शरीर में पानी की कमी भी हो रही है. तो लगातार 2-3 दिन उल्टी करने के बाद जब पानी की कमी ज़्यादा होने लगती है तो बच्चे की बॉडी कहती है कि भैया पानी को रोको, पानी को बचाओ. उसके लिए बच्चे की बॉडी में एडीएच, एल्डोस्टेरोन टाइप के हार्मोन ज़्यादा निकलना शुरू हो जाते हैं. अब ये जो हार्मोन्स हैं बच्चे की किडनी पे एक्ट करते हैं और कोशिश करते हैं कि जो भी सोडियम और वाटर है वो बच्चे की किडनी से वापस से एब्जॉर्ब कर ले. तो जब सोडियम और वाटर का रीएब्जॉर्प्शन होता है किडनी से, तो इसके बदले में पोटेशियम और एच आयंस का एक्सक्रीशन होने लगता है यूरिन में. सोडियम और वाटर तो अंदर आ रहा है बॉडी में, लेकिन पोटेशियम और एच आयन बाहर जा रहा है यूरिन में. यानी कि if suppose sodium and water is getting reabsorbed by the kidneys and potassium and H ions are getting excreted in urine, so potassium is getting lost in urine, which we call as kaliuresis, and there will be hypokalemia. In the blood, the potassium will go down, so there will be hypokalemia. If H ions are going out in urine, H ion mean acid. That means acid is going out in urine. So ideally what should have happened, beta? Baby was having metabolic alkalosis. Initially the urine was alkaline, trying to maintain homeostasis. But now when dehydration has become a priority, sodium and water is getting reabsorbed. Potassium and H ion is getting excreted in urine. H ion in urine, acid in urine. Ideally, the urine should have been alkaline, but urine has actually become acidic. This is called as paradoxical aciduria. Paradoxical aciduria. So these are the metabolic changes, what we can find in this baby. Now, generally, when these babies come to us in emergency, persistent vomiting, first thing what we have to do is we have to provide basic resuscitation. They might be severely dehydrated. So we have to give hydration to them. Rehydration, electrolyte correction. This is the first thing we are doing. Once we feel that now the baby is getting stable, we can examine these babies. We can feel an olive lump in the epigastrium. We can do a test feeding and see the vigorous peristalsis from left to right to confirm whether the lump what we are feeling, that is thickening of the pylorus or not. We can do a ultrasound. When we do a ultrasound, we can find something like this. Now ultrasound, beta, is a poor investigation in GIT. Wherever there is air in the body, ultrasound waves, acoustic waves, travel with difficulty through the air. That is why for GIT, ultrasound is not a very good investigation. That is why we are not able to see the things so clearly. Now this is just a comparison, beta. This is a part, what you're seeing is the stomach. This is the pyloric canal. This is the pyloric muscle. Here what you're seeing, this is the pyloric muscle. In this hypertrophy of the pyloric musculature, what has happened? The pyloric muscles have thickened, but the pyloric canal has narrowed. On ultrasound, if the thickness of pyloric muscle is more than 3 to 4 millimeter and length of pyloric canal more than 16 to 17 millimeter, then we believe that yes, we are dealing with a case of hypertrophic pyloric stenosis. In the treatment of these babies, we want that pylorus should become normal. We want to relax the pylorus. What we can try initially, beta, we can pass a upper GI endoscope, and through that we can pass a balloon catheter, keep the balloon at the site of stenosis and inflate the balloon, which can dilate the pylorus, just like what we were doing in angioplasty, right? So we can try doing this. However, the best results are obtained by surgery. In surgery, what we can do, beta, we can do a laparotomy, and this area what you're seeing, this is the pylorus. We can make a longitudinal incision on the serosa, cut the pyloric muscle. As soon as you cut the serosa and the pyloric muscle, the mucosa protrude out. So that is what we call as seromyotomy. Just a moment, beta. Right, beta. So this is all what we are doing for this pyloric stenosis. And now, if we come back here and if we try to fill it, just give me some time. It might take approximately 15 minutes, I guess. There's an urgent, the few people who are waiting outside, so I think I'll be back at 6:25 p.m. Right? Just relax for a moment, beta, and just try to analyze this hypertrophic pyloric stenosis. Thank you for your understanding and patience, beta. God bless you. Hello. Yeah, right, beta. So we were discussing about this hypertrophic pyloric stenosis. This is simply hypertrophy of the pyloric musculature. Usually, the first-born male child, for reasons not understood, beta, usually the first-born male child is affected. The incidence is 2 to 3 per thousand live births. This condition usually presents during third week of life. Now, this has been asked number of times, beta. They will cook you a story where they might give you a 17-day, 18-day old baby presenting with non-bilious vomiting, right? So you have to be careful here. And why it is not presenting at birth, I think we all are very clear. This is not a complete traffic jam story. It takes some time for the muscles to get hypertrophied, right? And then there would be stenosis, right? Now, clinically, these babies, they will present as a olive lump in the epigastrium. And please remember, beta, this lump what you're feeling, this is because of the thickened pyloric muscle. It is not the distended stomach which is felt as a lump, but it is the hypertrophied muscle which is felt as a lump. And when you give a test meal, suppose you give milk to this baby, you can see vigorous peristaltic movements of the gastric muscle moving from left to right. Visible peristalsis from left to right after test meal. Obviously, as you rightly said, beta, it will be a non-bilious projectile vomiting. That means with force. And because acid is getting lost, so there will be metabolic alkalosis. We also know the concept that whenever there is more alkali inside the body, generally the body kidney tries to throw the alkali out so as to maintain the normal homeostasis. That means initially the urine of this baby will be alkaline. But if this baby is vomiting continuously for 2 to 3 days, the baby is getting dehydrated. And because of dehydration, the water is getting lost. So the baby's kidney are trying to conserve water. That means the ADH aldosterone type of hormones, they will be stimulated and they will be absorbing sodium and water from the kidneys. When sodium is coming inside the body, then potassium and H ions will be excreted in urine. H ions going out in urine, this is aciduria. Ideally, because there is metabolic alkalosis, the urine should have been alkaline. But what is happening? Acid is leaking out in urine. That is why we call it as paradoxical aciduria. Since there is acid here, HCl here, and chloride is lost in vomiting, so there will be hypochloremia. Hypochloremia. Since potassium is going out in urine, there is kaliuresis. So there will be hypokalemia. Hypokalemia. Now this is going to be an extremely important area for your exams, beta. The examiners have been asking this clinical scenario a number of times. And this is just a basic concept what you have to remember, beta. Here we are talking about pyloric stenosis. This is a small baby. In case of adults, when we'll be talking about peptic ulcer disease, if there is ulcer in this part of the stomach or duodenum, and when the ulcer heals, then because of this ulcer healing, when the ulcer heals in this area, it causes fibrosis, and fibrosis will also be causing this narrowing. If the examiner gives you a situation of 60-70-year-old gentleman who was having a cancer inside the stomach, and if the cancer has become so big in size that it is causing traffic jam at the pylorus, whatever the cause, beta, look at me on the screen, whatever the cause, whether it is a small baby with pyloric stenosis or adult with peptic ulcer fibrosis or elderly person with stomach cancer, if there is pyloric stenosis, you know that the stomach is going to get distended and the intragastric pressure will increase, which will force the vomiting. So acid is going to get lost in these situations. Patient will have metabolic alkalosis. There will be hypochloremia, right? This story can be cooked in different ways by your examiners, and this is what you have to remember in all these stories, right? Okay. Now, how to approach these babies? 17, 18-day-old baby presenting with persistent vomiting. The baby would be dehydrated. So first thing we have to do, rehydration and electrolyte correction. Important to note, beta. Any patient who is presenting with abdominal mass, abdominal lump, the first investigation in all these situations will be ultrasound, ultrasound and ultrasound. Right? I repeat this in Hindi, beta. कोई भी हालात हो पूरे 19 सब्जेक्ट में, अगर फरवरी 2023 में कोई भी मरीज किसी भी उम्र का हो, बच्चे, बूढ़े और जवान, अगर पेट में गोला है तो पहला इन्वेस्टिगेशन हमेशा पेट का अल्ट्रासाउंड होगा. Whatever is the age, if the patient is presenting with abdominal mass or abdominal lump, the first investigation will always be ultrasound, ultrasound, ultrasound of the abdomen. And here, when we do a ultrasound, we can find thickened pyloric muscle. If the diameter of pyloric muscle is more than 3 to 4 millimeter or length of the pyloric canal more than 16 to 17 millimeter, this favors hypertrophic pyloric stenosis. Initially, we can pass an endoscope and a balloon catheter and try to dilate that stenosed area, that is pneumatic balloon dilatation, but the treatment of choice is surgery. In surgery, what we are doing is, I repeat this because I just saw a query wherein you wanted me to explain this Ramsted's, the seromyotomy. See, what we are doing here, beta, this what you are seeing is the pyloric area, right? This pyloric muscle has thickened, because of which the pyloric canal has narrowed. So what we are doing is, we are making a longitudinal cut on the serosa and the muscle. If you incise the muscle, beta, then the pyloric musculature will relax. And if the pyloric muscle relaxes, the lumen of the pylorus will become wide and the traffic jam will be cleared, right? This operation is called as Ramsted's seromyotomy. Ramsted's seromyotomy. Ramsted's seromyotomy. Beta, just a passing reference that when we'll be talking about adult surgical problems, we'll be talking about a pathology in the esophagus in adult surgical problems, that is achalasia cardia. In this achalasia cardia, there is a problem in the esophagus. What happens? The lower esophageal sphincter in the esophagus, if this is the lower esophageal sphincter, this fails to relax, and because of which this also creates a traffic jam type of situation here. If there is a traffic jam here in the lower esophagus, we can very well understand that the proximal esophagus is going to get dilated. This is what we actually see in cases of achalasia cardia, right? Now here also, when we are trying to do the treatment, we can try giving some medicines initially which can relax the smooth muscle. We can do a pneumatic balloon dilatation here also to relax this area. But the best treatment is cutting the muscle in this area. Here, if we are doing open surgery, we call it as Heller's myotomy. Now, why I wanted to stress on this, beta? Here, we are doing almost the same thing. We want to cut the muscle, but first we have to cut the serosa and then the muscle. So here we call it as seromyotomy. But when we are doing the same story in the esophagus, esophagus does not have serosa. So we directly cut the muscle. So here in achalasia cardia, we call it as myotomy. In pyloric stenosis, seromyotomy. In achalasia cardia, myotomy. Opening of something in surgery is stomy. If we are opening the muscle, we are calling it as myotomy. If we are opening the serosa in the muscle, we are calling it as seromyotomy. Right? Just a passing reference so that you remember this in adult surgical problems. So this is the story what we talked about in the epigastrium. We talked about duodenal atresia, annular pancreas, and hypertrophic pyloric stenosis. Just a quick recap of these three problems. Duodenal atresia, absence of some part of the duodenum due to failure of fusion of foregut with the midgut. Let me just remove this because the message is what I am receiving better. You are enjoying more, you are able to revise better when we are not using the workbook. Right. So let's do it once again, beta. The epigastric pediatric surgery stories, duodenal atresia, annular pancreas, and hypertrophic pyloric stenosis. Duodenal atresia, absence of some part of the duodenum due to failure of fusion of foregut with the midgut. Baby presents with bilious vomiting within few hours after birth. This pathology is the commonest cause of intestinal obstruction in a newborn baby. Overall, the commonest cause of intestinal obstruction is post-op adhesions. This duodenal atresia is also the commonest GI anomaly seen in Down syndrome. When we examine these babies, if we take the X-ray in these babies, we can see a double bubble sign. Because wherever there is traffic jam in the duodenum, the proximal duodenum will dilate separately. Then there will be pyloric sphincter which will not dilate, and then the stomach will dilate. So we are seeing two bubbles in duodenal obstruction. Single bubble, pylorus, double duodenal, triple jejunal, multiple central small intestine, and multiple peripheral large intestinal obstruction. In the treatment of this duodenal atresia, ideally we just have to connect the proximal and the distal duodenum. So we are doing a duodenostomy. If by chance the two ends of duodenum are far from each other and we cannot do a duodenostomy, we request the jejunum, bring the jejunum close to the duodenum and do a duodenojejunostomy. That is the alternative treatment. Annular pancreas is just a ring of pancreatic tissue which surrounds the duodenum. Since this is the case of duodenal obstruction, on X-ray we'll find a double bubble sign, and the treatment will be same as duodenal atresia, duodenostomy, alternative duodenojejunostomy. Congenital or infantile hypertrophic pyloric stenosis. This is not atresia. This is simply hypertrophy of the pyloric musculature. Usually the firstborn male child is affected, 2 to 3 per 1,000 live births. Usually presents during 3rd week of life. Overall between 2nd to 6th week of life. Now, due to hypertrophy of the pyloric muscle, there is stenosis of the pyloric canal, a sort of gastric outlet obstruction. Because of this, the baby would be presenting with projectile non-bilious vomiting between 2nd to 6th week of life, commonly during 3rd week of life. Because of this thickening of the pyloric musculature, we can feel an olive lump in the epigastrium. And if we give a test meal to this baby, we can see vigorous peristalsis movements of the stomach moving from left to right. Because baby is vomiting out acid, so there will be metabolic alkalosis inside the baby. The kidneys will try to throw the alkali out initially. Initially, the urine of the baby will be alkaline. But if the baby is persistently vomiting for 2 to 3 days, the baby will be getting dehydrated, and dehydration becomes a priority for this baby now. Then the baby's water conserving mechanisms will be stimulated. ADH, aldosterone will be stimulated, who will try to conserve sodium water from the kidneys. When sodium is getting reabsorbed, then potassium and H ions will be excreted in urine. If H ions are going out in urine, this is acidic urine, so we call it as paradoxical aciduria. Since chloride is getting lost in vomiting, there will be hypochloremia. Potassium going out in urine, kaliuresis, less potassium in the patient, hypokalemia. In our clinical approach, if the baby is presenting an emergency with profuse vomitings, then first thing to be done is rehydration, electrolyte correction, make the baby stable. Then we can do an ultrasound And on ultrasound, if the thickness of pyloric muscle is more than 3 to 4 millimeter and length of pyloric canal more than 16 to 17 millimeter, then it favors the diagnosis of hypertrophic pyloric stenosis. In the treatment, initially we can try doing a endoscopic balloon dilatation, pneumatic balloon dilatation, but the best treatment option is surgery, where we cut the serosa and the muscle, that is Ramstedt's seromyotomy. Right. Now, moving further into the right hypochondrium, this is the area for liver and gallbladder. So let's take a look what congenital problems we can see, or what pediatric surgical problems we can see in this right hypochondrium. So herein we have got few things like biliary atresia, choledochal cyst, and intussusception is something which is related to intestine. We'll also discuss that intussusception in this right hypochondrium only for a particular reason, which we'll see later. So beta, if we try to take a look at the basics, this right hypochondrial area, suppose this is the liver, we know that bile is produced by liver, and then there are biliary channels. Instead of drawing it here, let me try drawing it here. There are biliary channels like the right hepatic duct, the left hepatic duct. They join to form the common hepatic duct. The common hepatic duct is joined by the duct of gallbladder, which is called as the cystic duct. Now the cystic duct and common hepatic duct, they join to form the common bile duct. And this common bile duct joins with the pancreatic duct to open in the second part of duodenum at the ampulla of Vater, which is guarded by the sphincter of Oddi. Right? So this is the normal story. We all know that bile is produced by liver, and the job of bile is emulsification of fats, which help in digestion of fats. So in normal person like you, what usually is happening, the bile is coming into these channels, the bile is going into the intestine, the bile is also going into the gallbladder. Gallbladder is something which is not for synthesis of bile, but it stores the bile. Why the storage is required? Because if suppose you take a bulky fatty meal, अगर बहुत सारा मक्खन आप एक साथ खाएंगे, when you take huge amount of fat in the meal, now you know that you are taking this meal from the mouth, esophagus, stomach and duodenum. So when this huge amount of fat is coming here, you may need huge amount of bile for emulsification. So in those stages, the gallbladder will contract and will throw huge amount of bile here. That is how the fats can be broken and can be digested and absorbed in the body. Right? This is something normal. Suppose the liver goes on a strike and liver does not produce bile. We can understand that whatever fats will be coming here, if no bile is coming here, the fats will not be emulsified, they will not be digested, and they will be passed as such in the stools. That means if this patient takes the makhan, this butter will go inside and it will pass as such in the stools. Makhan jaise stools. Steatoria, fat in the stools. Right? So that is why bile is so very important. Another scenario. If suppose there is any traffic jam situation in this biliary channel, suppose I say that I just press this bile duct. If I just press this bile duct, what will happen? The bile is not going to come into the intestine. So fats will not be digested. They will be passing as such in the stool. Malabsorption, steatoria. Apart from this, if Bile is being produced by the liver, but it is not allowed to go into the intestine. All this bile will get collected in this. The proximal people are going to get dilated, and the bile pressure inside the liver will increase. Inside the liver, there are small biliary channels and sinusoids. So when the biliary pressure will increase, this bile will start entering into the sinusoids in the liver, from where this bile is entering into the blood. Bile in blood, jaundice. This is what is a surgical jaundice, obstructive jaundice. Whatever is the cause, if there is any traffic jam in the biliary channel, bile is not going down, bile is going up. The proximal people are going to get dilated, biliary pressure in the liver will increase, and this bile will enter into the blood. Bile in blood, jaundice, surgical jaundice, obstructive jaundice. Right? This is the basic conceptual thing. Now let us try to put different clinical situations here. There is one thing called as biliary atresia. Atresia means absence. If by chance God has not made these biliary channels, for example, if suppose I say God has not made this common bile duct, that means there is a traffic jam here. What will happen? The proximal people are going to get dilated. Jaundice. Fats are not getting digested. Steatorrhea, malabsorption. This is going to be the presentation if biliary channels are absent. This is one story, beta. Another story. Sometimes in babies only, in pediatric surgery only, we find abnormal dilatations of the bile duct. Abnormal dilatations of the bile duct. This is called as a choledochal cyst. Docoduct. Cholebile. Choledochal cyst. Sometimes in these situations, there is a possibility that bile starts staying in this particular area. Bile starts staying in this particular area, and this creates some sort of traffic jam type of situation. In this situation also, there is a possibility that patient will develop jaundice, right? If this is trying to create a traffic jam type of situation. Another story. If we talk about adult surgical problems, we commonly talk about stones inside the gallbladder. Now, if I say that some patient has formed stones inside the gallbladder, and if this stone by chance slips through the cystic duct and comes into the common bile duct, this is also going to cause the same story, right? Or if I say that probably the patient has had some infection in the bile duct, infection of the bile duct is called as cholangitis. Chole, bile, angio, vessel, cholangitis. So if there is inflammation of the bile duct, which may lead to healing by fibrosis, and because of fibrosis, suppose stricture develops in the bile duct, narrowing in the bile duct, that will also present with the same story what we are discussing. In case of elderly people, if I say that by chance this gentleman has developed a cancer in the bile duct, again beta, the same story. This is how conceptual knowledge is so very important. The name of the diseases may be different. The age of presentation of diseases may be different. But the concept will always remain a concept. The common sense will always remain a common sense. Right, beta? So herein, if we now discuss the different problems in pediatric surgery, we'll be talking about two things here: biliary atresia and choledochal cyst. Both these topics are important for us. We have been getting questions from biliary atresia. This time we had a question from choledochal cyst. Right? Okay, fine. Let's take a look. What can be the different? I hope, beta, you have got this concept nicely, that what is normal, what can be the different problems related to biliary channels in pediatric surgery, adult surgery, elderly, right? Okay. Biliary atresia simply means absence of biliary channels. Absence of biliary channels means these hepatic ducts in the bile duct. Why these bile ducts may be absent, the exact cause is not known, but it is believed that probably within few days of life, maybe 4 days, 5 days, 7 days of life, there may be some inflammatory reaction in the bile duct which is causing fibrosis and narrowing of these bile ducts. Depending on which bile ducts are absent, we can categorize this biliary atresia into three types. Look at the screen carefully, beta. Look at me here. If I say that only common bile duct is absent, this is type 1. If I say that common hepatic duct is absent, this is type 2. And if the right and left hepatic ducts are absent, that will be type 3. Now, I'm scared, beta, because as soon as I'll put my rubber on the right and left hepatic duct, the liver will also be gone. Let the liver be gone. Okay. But here in type 3 biliary atresia, the liver will definitely be there. So type 3 atresia will be something like this. No right and left hepatic duct, common hepatic duct or bile duct. These are the three different types of biliary atresias, right? Okay. So biliary atresia, this is basically absence of biliary channels. Exact cause is not known, but it is believed to be due to inflammatory fibrosis of biliary channels starting in the first week of life. Three types. Type 1, absence of common bile duct. Type 2, absence of common hepatic duct. Type 3, absence of right and left hepatic duct. Type 3 is the most common type. Most common type is type 3. That means there are no biliary channels. Bile will be produced inside the liver. Bile will remain inside the liver. Bile will be going into the blood. The baby will be having jaundice. Bile is not coming into the intestine, steatorrhea. Because of biliary congestion in the liver will get enlarged, hepatomegaly. And this story presents in the first week of life. Since the presentation of the baby is jaundice, another important thumb rule: any patient who presents to you with jaundice, first investigation will always be liver function test. First investigation always will be liver function test. And then For the right hypochondrial problems, we can do the ultrasound. To look for these biliary channels, what investigation should be done? For the biliary channels, there are various investigations, like there is ERCP, there is MRCP, there is HIDA scan. These are various investigations for biliary channels. You can just make a note, investigation for biliary channels. Investigation for biliary channels. ERCP, MRCP, HIDA scan. Now this ERCP, this is endoscopic retrograde cholangio pancreaticography. MRCP is magnetic resonance cholangio pancreaticography. And HIDA scan. This is an isotope scan. Now, how these investigations are done? If we talk about ERCP, लिख लिया बेटा? I hope you have written. Okay. Now, if we talk about ERCP, look at me on the screen, beta. Here. Now we know here there would be stomach, and then here would be the esophagus, right? So this esophagus right here, and then there will be mouth. So what we can do here is we can pass a endoscope through the mouth, or I'll use some other color, right? We take the endoscope, we pass this endoscope through the esophagus into the stomach, pass this endoscope into the duodenum, and then we keep the endoscope here. Then we push some contrast agent. We push the contrast, and the contrast is going into the bile duct as well as the pancreatic duct. And then we take the X-ray. So we can see the contrast going nicely into the common bile duct. This contrast would be going into the cystic duct, into the gallbladder, into the common hepatic duct, into the right hepatic and the left hepatic duct. This contrast will also be going into the pancreatic duct. This is what we say endoscopic, cholangio. Cholangio means, chole means bile, angio means vessel. Pancreatico, taking the X-ray, graphy. Endoscopic, retrograde. We are going from this point, terminal part of CBD, right? Retrograde. You're not going like this. You're not putting the contrast from above downwards. You're putting the contrast from below upwards. So retrograde. Cholangio pancreaticography. Right. So that is how we can study these biliary channels. Okay, ji. MRCP is simply MRI of the biliary channels. This is a non-invasive investigation. We don't put anything inside. The bile itself acts as a contrast and we can see the biliary channels nicely. HIDA scan is an isotope scan. Now, what generally we do in a HIDA scan, first let me just try to explain. This is an isotope scan. So what we are doing here is we inject an isotope into the peripheral vein, right? And this isotope goes through the circulation, then it comes into the liver. The liver cells, hepatocytes, excrete this isotope into the biliary channels. Hello? Yeah. So this isotope is excreted into the biliary channels. And then we take the X-rays. And we can see the flow of this isotope from the liver into the biliary channels right up to the duodenum. I repeat this better. In HIDA scan, this is an isotope scan wherein we inject the isotope into the peripheral vein. This isotope travels through the circulation Hello. Hello. Yeah. So basically, if we try to look that how this HIDA scan is done, suppose we are just trying to imagine this situation only. The isotope has been given through the peripheral vein. Now through the circulation, the isotope has come into the liver, and this isotope is getting excreted by the hepatocytes, and this is going to come into the biliary channels. With the help of special gamma camera, you can see that how this isotope is traveling through these biliary channels. Right left hepatic duct, common hepatic duct, it will be going into the common bile duct and into the duodenum. This isotope will also be going into the cystic duct and would be filling the gallbladder also. Right. So that is how we can study these biliary channels with the help of HIDA scan. Now, which investigation should be chosen for biliary atresia? This is a 7-day-old baby. 7 दिन का छोटा सा बच्चा है. ERCP in this small baby is going to be difficult. ERCP in the small baby is going to be difficult and challenging. So we cannot do this ERCP. MRCP is also going to be difficult in the small baby. Herein, I would like to add one more thing. If you just try to take a look, beta, we said that what was biliary atresia? Biliary atresia was absence of biliary channels. And suppose we are talking about this type of biliary atresia, and suppose you have to do a ERCP. In ERCP, what we do is we pass the endoscope through the mouth, and then it is coming through the esophagus, stomach into the duodenum, and then we put the endoscope here and then push the contrast. But problem is, in biliary atresia, whether it is type 1, type 2 or type 3, type 1 is absence of CBD. So where are you going to put the contrast? There is no place to put the contrast. Whether it is type 1, type 2 or type 3, there is no CBD in all three types. That means ERCP is actually not possible in biliary atresias because there is no CBD. Okay. MRCP is basically MRI, and MRI is something which is avoided in small babies. Generally for MRI it takes around 40-45 minutes time, and the patient has to lie in that MRI machine on the MRI table still without making any movement. If the patient makes any movement when the MRI is going on, this gives lots of motion artifacts on the screen. And here we are talking about a 7-day-old baby. 7 दिन का छोटा सा बच्चा है. If you ask this baby to lie still on the MRI table, the baby may be looking at you, and the baby would be doing wah, wah, wah. He would be moving like this. So MRI will not be possible in this small baby because of huge amount of motion artifacts coming on the screen. That means if we have to study biliary atresia, ERCP is not possible. MRCP is not possible because this is a small baby. The only option left with us is give a isotope into the peripheral vein of this baby, let the isotope go into the liver, let it be excreted. If it is type 1 biliary atresia, then the isotope will be seen coming right in this area. And the isotope will be arrested here, and you will come to know that yes, this is a type 1 biliary atresia. If suppose it is a type 2 biliary atresia, that means the common hepatic duct is not there. So on a HIDA scan, what you will be seeing is the isotope would be getting arrested here like this. So you will come to know, yes, this is a type 2. And if suppose it is a type 3, then obviously you will not see any biliary channel. You will just see that all the isotope is actually inside the liver only, no biliary channel. So that is how we can diagnose these biliary atrasias on HIDA scan. HIDA scan. Right. This has been asked quite frequently, beta. What is the investigation of choice for biliary atrasia? The answer is HIDA scan. Right? Now comes the treatment part. What should be the treatment for this biliary atrasia? Suppose this is the liver. And if we are talking about type 1 biliary atrasia, type 1 is absence of CBD. So there will be right hepatic duct, there will be left hepatic duct, there will be common hepatic duct, but no common bile duct, right? What we can do in this case, let me try to draw it. Suppose this is the esophagus, this is the stomach, this is the duodenum, the third part of duodenum, the fourth part of duodenum, and here suppose is the jejunum, like this. What we are talking about, suppose here is the liver, and these are the biliary channels, and we are talking about a pathology where there is type 1 biliary atrasia, something like this, right? I hope this is clear, beta. There is no common bile duct. If there is no common bile duct, then what is happening? Ideally, if the common bile duct would have been there, then the common bile duct would have been opening here in the second part of duodenum. But there is no common bile duct here. That means now there is nobody to bring the bile from the liver into the intestine. What we can do is, we can take the help of the innocent guy, that is the jejunum. What we can do is, we can request this jejunum here. We can transect the jejunum at this area, and we can lift this part of the jejunum, take this jejunum here and connect with the common hepatic duct. Now if you connect with the common hepatic duct, the jejunum would be coming somewhat like this. I think let me redraw it. I'm not convinced with this, because this is something which is very crucial for our understanding. Okay, let me use this space. Suppose this is the esophagus, this is the stomach, this is the duodenum, the third part, the fourth part, the jejunum, the jejunum, the ileum like this. And here, suppose I say that here lies the liver. And there are biliary channels which are supposed to come out from the liver. The right hepatic duct, the left hepatic duct, the common hepatic duct, and then there will be common bile duct which will be coming in the intestine. But in biliary atresia, if this CBD is not there, then either we have the option of joining. Abhi kya kare? If we just focus in this particular area, there is no CBD. We want that this bile should come in the intestine. So one option is we can try joining this common hepatic duct with the duodenum. But the problem what we know already, that this area here there is pancreas, and duodenum is inseparably fused with the pancreas. So it is not practically possible to move this duodenum towards the common hepatic duct. If we try to move the common hepatic duct, if you just try to pakdo this common hepatic duct and try to khicho this common hepatic duct, because these biliary channels are embedded inside the liver, if you try to pull these biliary channels will come in your hand. That means we are not able to join this common hepatic duct directly with the duodenum. So we have to think of something else. We know that God has given one innocent guy in GIT. This intestine is freely mobile. So let us ask this jejunum, will you help us? And the jejunum is always ready. So what we can do here, if suppose this was the jejunum, we transect the jejunum at this point. And then this jejunum, we lift it from here and bring it here. And we connect this jejunum with the common hepatic duct here. This jejunum is going down as the ileum. What we can do now is, we know that pancreatic duct would be coming in this area. Here would be the pancreatic duct. That means pancreatic juice is coming here. We also know that whatever food the patient is taking, that food is also coming here, right? If we leave this open like this, the food and the pancreatic juice will leak into the peritoneal cavity. So what we can do is, we are able to understand that bile is coming from here, but food is coming from here, and pancreatic juice is coming from here. We want that food should be digested by the pancreatic enzymes as well as the bile. So we can connect this jejunum with this jejunum. If you connect this, you can see nicely that food has come here. You can see that pancreatic juice is coming here, and you can see that bile is also coming here. That is how the food is mixed with the bile as well as the pancreatic juice, and our purpose is solved. And since we are making a letter Y, so we call it as Roux-en-Y hepatico-jejunostomy. Hepatico-jejunostomy. This is the treatment what we are doing for type 1 biliary atresia. Common biliary atresia is type 3. That means there are no biliary channels. Now, beta, if there are no biliary channels, then there is a major challenge. In this something like this. Bile is being formed inside the liver, but there is nobody who is coming from the liver which can be connected with the jejunum. So now how to bring the bile into the intestine? We know we have got only one innocent guy, that is jejunum. So we again request this jejunum that, look, my dear jejunum, what you have to do is you have to go to the liver. We transect the jejunum here. We take this jejunum here. Now jejunum is innocently asking us, doctor, is there somebody who would be coming from the liver so that I can connect with that? But there is nobody coming from the liver. We just request the jejunum, you just get attached inside the liver. Whatever amount of bile you can drain, that will be okay for us, at least for some time. So we just connect this jejunum directly into the liver at the porta hepatis of liver. And then down, we know that we have to follow the same story here. Now this type of operation where we are connecting the jejunum directly into the liver, this is hepatico-porto-enterostomy. Hepatico-porta hepatis, entero means the intestine, that is the jejunum, stomy, hepatico-porto-enterostomy. And this type of operation where we are just putting the jejunum into the liver is called as Kasai operation. Kasai operation, right? Type 3 biliary atresia is quite common in Pakistan and Kasai operation is commonly done in Pakistan, right? Eventually what will happen, because the biliary channels are not there, this jejunum will not be sufficient to drain all the bile from the liver. Gradually, the bile congestion will be there inside the liver, which will put chronic pressure on the hepatocytes and the liver will fail. If the liver fails, we are left with only one option: remove the failed liver, buy a new liver from the market and put it. That is liver transplant, right? So that is how we are treating these biliary atresias. In the treatment beta, for type 1 biliary atresia, we are doing Roux-en-Y, hepatico-jejunostomy. While for type 2 and type 3, we are doing a MCQ operation, that is a Kasai operation. MCQ people have asked, this Kasai operation is done in biliary atresia. This is hepatico-porto-enterostomy, but eventually these patients will require liver transplant. Eventually, these patients will require liver transplant. So this is all about the story of biliary atresias. Herein, we have tried to discuss a lot of aspects which can be there in the biliary channels. Name of the pathologies may be different, but the presentations and the treatments would be more or less the same, right? Let's revise whatever we have discussed in this right hypochondrium. We just talked about biliary atresia. This is absence of biliary channels. Exact cause is not known, but probably it is due to inflammatory fibrosis of the biliary channels happening in the first week of life. We can classify them into 3 types. Type 1, absence of CBD. Type 2, absence of common hepatic duct. Type 3, absence of right and left hepatic duct. Most common is type 3 biliary atresia. If there are no biliary channels, the baby will present with jaundice, steatorrhea, hepatomegaly. First investigation in any patient presenting with jaundice will be liver function test. We can do ultrasound for the right hypochondrium. In the management, in the investigations, we cannot do ERCP for biliary channels because there is no CBD. MRCP is not possible in small babies because of motion artifacts. Investigation of choice is a HIDA scan, and that gives us whether it's type 1, type 2 or type 3 biliary atresia. In the treatment, if it is type 1 biliary atresia where only CBD is absent, we can connect the jejunum with the common hepatic duct, that is a Roux-en-Y hepaticojejunostomy. But if it is a type 2, type 3, like type 3 biliary atresia where there are no biliary channels, we directly connect the jejunum into the liver, that is Kasai operation, hepaticoportoenterostomy. But this will not be sufficient to drain all the bile. Eventually, there will be biliary congestion over a period of time, maybe 2 years, 3 years time, and the liver is going to fail. If the liver fails, we don't have any option but to do a liver transplant. Thank you very much for your patience, Peter. May God bless you all. May you remain pumped up. May you remain positive. God is watching you. Always be honest to yourself. Try to focus as much as possible and try to get the maximum output. Rose, rose, daily basis. We have to make consistent efforts. We have to keep on fighting out daily. We have to keep on grinding out daily. रोज जैसे मजदूर होते हैं ना, रोज पत्थर तोड़ते हैं. Just like the laborers, they are just trying to dig every day, every day, every day. That is what we are supposed to do. We have to keep on doing these consistent efforts on a daily basis. And if we are honest to ourselves, if we are able to maintain that positivity, if we are able to help others, if we are able to take the blessings of our parents or elders, then definitely, if we are not doing anything wrong for anyone, God will also not be doing anything wrong for us. And 17th of December, He will help us. If we are honest to ourselves, He'll definitely be honest to us and will definitely come out with flying colors. May God bless you all. Wish you all the best. Have a great night. And now I'm here to sort out your queries. If you have got any queries, please do write to me. Thank you very much. Right, beta. So now let's take a look at the queries. Shinu from KNMU beta, seromyotomy. That is when we are cutting the serosa and the muscle layer. In the GIT beta, generally we have got mucosa, submucosa, muscle, serosa. These are four layers of your GIT wall. Right? In the abdomen, wherever there is peritoneum, the outer layer is serosa. But in the body, wherever there is no peritoneum, there is no serosa. So whenever we have to relax the muscles of the stomach and we are doing the operation from outside, suppose laparotomy, and then you are approaching the stomach, then first you cut the serosa, then you cut the muscle. You do not cut the submucosa or mucosa, because if you cut the mucosa, then it will become a perforation, right? So we are just cutting the serosa and the muscle, and that is what we call as seromyotomy. Prakar from Musgrowth, he has asked a query regarding the question in the workbook that if it was difficult to extubate the patient by the anesthetist after total thyroidectomy, the most probable diagnosis. Beta, extubation is not possible because of vocal cord paralysis, and this vocal cord paralysis can occur if there is injury to both the recurrent laryngeal nerves. Yeah, today we had some sound issues, beta, and really I'm so glad, beta. Let me thank you so much, so very much, that there are so many messages regarding the sound. That sound has gone, and I'm really thankful to you, beta. It just shows your dedication. That though I'm trying to be very very slow in these classes, despite that, your dedication is commendable, beta. I hope you got the retrograde meaning, Abhishek from Dali. Yes, Sandeep from Harbin Beta. How will differentiate between duodenal atresia and pyloric stenosis on X-ray? Beta, pyloric stenosis will have only one bubble. Duodenal atresia will have two bubbles. We cannot differentiate duodenal atresia with annular pancreas on X-ray. For that, we have to do a CECT. Rahul, we don't use shock waves in gallbladder stones because uh, even if we use shock waves and try to break the stones, the diameter of cystic duct, that is the duct of gallbladder, is 1 to 3 millimeter. So for that we need to actually break the stone to size less than 1 millimeter, which is not practically possible with these shock waves. Apart from this, there are high chances that if we leave the gallbladder inside, if the stones have occurred, there are chances of gallbladder developing malignancy later. Firdosh, in HIDA scan beta, we are giving the isotope in the peripheral vein. This isotope travels through the circulation into the liver, and from the liver this isotope is excreted by the hepatocytes so that it goes into the right and left hepatic ducts, common hepatic duct, cystic duct, gallbladder, and also in the common bile duct, and then it clears off in the intestine. Usually within 1 hour, all the isotope which we have given that passes from the liver through the biliary ducts into the duodenum and intestine. So if we are taking the images from gamma camera within first 30 minutes to 60 minutes after injecting the isotope, we can see the biliary channels nicely. And if God has not formed the biliary channel, we will not see that particular biliary channel on HIDA scan. Janish from China Medical University, beta. Could you please elaborate a little on paradoxical which is seen in congenital hypertrophic pyloric stenosis? Yes, I'll do that once again, beta. Generally, what happens in a patient who is having pyloric obstruction, there will be vomiting of gastric contents, that is vomiting of acid. So, acid will be lost from the body and there will be metabolic alkalosis. Body will try to compensate for this. Kidneys will try to throw the alkali out, so the urine would be alkaline, which is true in the initial 1, 2 or 3 days. But if the patient is continuously vomiting out, patient is also getting dehydrated, and because of dehydration, the kidneys want to conserve water inside the body. So ADH and aldosterone are stimulated and they reabsorb sodium and water from the kidneys. When sodium is getting reabsorbed from the kidneys, then potassium and H ion is excreted in urine. If H ion is going out in urine, H ion means acid. So acid is going out in urine. Ideally, alkali should have been going out because there is metabolic alkalosis inside. But if acid is going out in urine, we call this as paradoxical aciduria. Hope this helps, Janish. Ali from Karasin, post-operative adhesions, beta, whenever we are doing any open surgeries for the abdomen, when we are handling the intestines, we might be causing some injuries to the outer layers of the intestine in handling. After few years of this operation, we have seen that probably due to healing by maybe some fibrosis, the different loops of the intestine may get adhered to each other, creating a traffic jam situation in the intestine, that is intestinal obstruction caused by adhesions of the intestine after operation. Dhritiman from Uskrot. A fluctuation simply means in context of breast abscess, if there is good amount of liquid collection in a localized area, then we will be able to elicit the clinical sign of fluctuation. What the difference between slit like? Slit like is just a line type, and circumferential means it is circular type. Rishabh from Davao. Yes, treatment options of biliary atresia. Will the bile mix adequately with the food in Kasai operation or Roux and Y? Roux and Y, because adequate bile will be coming in Roux and Y if the hepatic duct is there. If it does not mix well, will the patient still have steatorrhea? Yes, if it does not mix well, definitely the patient will have steatorrhea. Beta. Rishabh from Davao, right. Please mention your details, Beta. I got it, Deepak. Deepak from Orenburg. You have asked to explain the concept of metabolic alkalosis and paradoxical aciduria in Hindi. Definitely yes, बेटा. कोई भी ऐसे हालात हो जिसमें पाइलोरस में ट्रैफिक जैम लग गया है, स्टमक डायलेट हो जाएगा और प्रोजेक्टाइल वॉमिटिंग शुरू हो जाएगी, और जो भी स्टमक के कंटेंट्स हैं वो वॉमिटिंग में बाहर निकल जाएंगे. अब स्टमक में बेटा क्या होता है? एसिड होता है. तो जब ये एसिड बाहर निकलेगा, अगर एसिड बॉडी से ज़्यादा बाहर निकल गया बेटा, तो बॉडी के अंदर एसिडोसिस होगी या एल्कलोसिस होगी? एल्कलोसिस होगी, क्योंकि एसिड निकल गया. अगर मेटाबॉलिक एल्कलोसिस हो रही है बॉडी में, तो जो किडनीज हैं वो कोशिश करेंगी कि भैया एक नॉर्मल बैलेंस मेंटेन करें. तो अगर बॉडी के अंदर एल्कली बढ़ रहा है तो किडनी एल्कली को यूरिन से निकालेगी, यानी कि यूरिन एल्कलाइन होना चाहिए. और ऐसा पहले 1-2-3 दिन में होता भी है. लेकिन बेटा अगर कोई पेशेंट लगातार वॉमिटिंग कर रहा है तो पानी की भी तो कमी हो रही है. अगर वो डिहाइड्रेट हो रहा है तो डिहाइड्रेशन ज़्यादा इम्पॉर्टेंट हो जाता है, और ऐसे में किडनी को पानी को बचाना चाहिए. तो एडीएच एल्डोस्टेरॉन टाइप के हार्मोन स्टिमुलेट हो जाते हैं, और फिर किडनी की टिब्यूल्स जो हैं पानी को बचाने के लिए ये एडीएच एल्डोस्टेरॉन की वजह से सोडियम और पानी इन दोनों का रीएब्सॉर्प्शन कराते हैं, मतलब इनको बॉडी के अंदर रोकने की कोशिश करते हैं. और जब भी हम सोडियम को अंदर खींचते हैं बॉडी में किडनी से, तो किडनी को किसी न किसी को तो बाहर भेजना पड़ता है. किसको बाहर भेजें? तो जाता है पोटेशियम और एच आयन. अगर पोटेशियम यूरिन में निकलेगा तो हम बोलते हैं कैलीयूरेसिस. अगर पोटेशियम ज़्यादा यूरिन में निकल गया तो बॉडी के अंदर पोटेशियम कम हो जाएगा ना, इसको बोलते हैं हाइपोकैलीमिया. अगर एच आयन यूरिन में निकल रहे हैं, एच आयन क्या होता है? एसिड. अगर एच आयन यूरिन में निकल रहा है तो यूरिन कैसा हो गया? एसिडिक. बॉडी में अगर देखा जाए बेटा तो कोई उल्टी कर रहा है तो एसिड निकल रहा है, मेटाबॉलिक एल्कलोसिस हो रही है तो यूरिन होना चाहिए था एल्कलाइन. लेकिन पानी को कंजर्व करने के चक्कर में एच आयन्स जो यूरिन में निकल रहे हैं उससे यूरिन हो जाता है एसिडिक. इसको अपन बोलते हैं पैराडॉक्सिकल एसिडोरिया. उम्मीद है दीपक इससे मदद मिलेगी बेटा. Translucent and transillumination. Translucent is something where we can see through it, and transillumination, if we are throwing the light and we are seeing the transmission of light. Extravasation means more secretions coming out. Retention means secretions getting trapped inside. Which disease you have to do ultrasound or X-ray? You will gradually come to know, beta. Just have little patience. Let few more classes may pass. Let radiology classes may also be done. Then you will be having a nice clear concept. Actually, this isotope, Mahesh from Amabita, this isotope is excreted through the liver. So it passes down in the stools. So the chances of damaging the kidneys of the newborn baby are not that much. Devika from Irkutsk, beta, in distended stomach with gas, what is actually happening? Basically, that was just to tell you that in esophageal atresia, if there is no fistula of lower esophagus with the trachea, then since there is esophageal atresia, the air from the mouth will not be going into the stomach, so you will not be seeing the gas inside the stomach or the intestine. But most common type of esophageal atresia is when the upper esophagus is blind and the lower esophagus communicate with the trachea. So if there is a tracheoesophageal fistula, the tracheal air can go into the esophagus and then air will be seen in the stomach and the intestine. So if you are seeing air in the stomach and intestine, it means that the lower esophagus is connected to the trachea. Imran from Kharkiv, beta, all on birth till large on vomiting basis means more vomiting. What's the limit? What are signs of large and small intestinal? A small and large intestinal obstruction, Simran. In small intestinal obstruction, what will happen? Wherever there is a traffic jam, whether it is small or large intestine, the proximal people are going to get dilated. The proximal pressure is going to increase. Now, if you just imagine small intestinal obstruction, then the proximal small intestinal loops will be dilated and there will be distension majorly confined in the central part of the abdomen. Plus, in the vomiting, it will be the small intestinal contents which are coming out. Plus, the patient will have constipation, severe pain, which will be more pronounced in the central part of abdomen. While if it is a large intestinal obstruction, the pain will be all over the abdomen. In vomiting, sometimes even the fecal matter may come out in vomiting. Feculent vomiting can occur. There will be gross distension of the abdomen because it is large intestine which is getting distended. And definitely there will be constipation. Beta, please do mention your name and university. In esophageal atresia, acid is secreting in stomach, but there is no food content seen due to atresia. Will it cause any further complications? Beta, we are doing the correction on day 1 or day 2 of life. If we are not doing the correction, we are waiting for 4 to 6 weeks in esophageal atresia. Then we are giving the required diet through a tube into the jejunum. For biliary channels in adults, beta, investigation of choice would be MRCP, magnetic resonance cholangiopancreatography. What is LUSM? Or this is ISM, I guess. Bashir from ISM, I guess. Right. Beta, please do mention your name and university. Thank you so very much for such nice words of appreciation, Beta. May God bless you. I have a doubt in thyroglossal cyst. As you told, we'll remove the cyst and tract. Will there be any complications after that? No, there won't be any complications after that, because generally also God obliterates this thyroglossal tract completely. On the last 5 digits, 82213, please do mention your name and university, Beta. In biliary atresia, type 1 CBD, type 2 absent, or both CBD, CHD, or only both CBD and CHD is absent, Beta, in type 2. Gallbladder is also gone. Jaydeep from UV Gulas, Beta. Sir, because of Kasai surgery, patient will not get enteral feed. So there will be any chance for mucosal atrophy? Yeah, there are chances of mucosal atrophy, but that would be only in a limited part. In the diagram, we saw that it was a quite lengthy part, but generally the limb length is not more than 20 centimeters. And further, can you please explain? I hope you got it, Beta. Thank you, Beta. Thank you so very much. Need your blessings, Beta. Need your these positive words, because these keep me pumping, keeps me motivating also, keeps me pumping to work even harder, Beta. Thank you so much, Jaydeep. Ashok from Orenburg, Beta. Thank you once again for your so nice, kind words of appreciation, Beta. Your question is initial fluid of choice in burn is ring lactate. Why not normal saline? We can also give normal saline, but there is a lactate depletion as well. So we prefer giving a solution which has also got lactate in burn patients. And second question, in duodenal atresia annular pancreas, after duodenogenostomy, we remove rest part of the duodenum. Generally, we don't remove rest part of the duodenum, Beta. It gets atrophied. Please do mention your name and university, Beta. Can you please explain once again why hepatico leads to liver transplant, although we have made connection for flow of bile? Yes, Beta. We are directly connecting the jejunum into the liver. God has not formed any defined biliary channels in the liver. So, even if you connect the jejunum directly into the liver, there is no defined biliary channel. Whatever hepatocytes are forming the bile, the jejunum is just trying to drain some of the hepatocytes, not all the hepatocytes. So the bile keeps on collecting inside the liver, which increases the pressure inside the liver, damages the hepatocytes in 2 to 3 years' time. And if all the hepatocytes are getting damaged, or more than 20-30%, more than 60% of hepatocytes are getting damaged, then the liver is going to fail, Beta. Heer Patel from Davao. Yes, Beta. Will gallbladder also absent? Yes, gallbladder will also be absent. Aarti from Orenburg, Beta. Very good evening to you. Can you re-explain duodenojejunectomy in duodenal atresia? Since the remaining end of the duodenum will just stay in the abdomen, if we connect the upper end of the duodenum with jejunum, yeah, the first part of the question, Beta, we are just connecting the jejunum with the proximal duodenum. That is fine. Generally, the remaining part of the duodenum, that is the third, fourth part of the duodenum, we don't remove that because that is fused with the pancreas. It gets atrophied on its own. Same in the case of annular pancreas. We cannot remove the annular pancreas beta because it is fused with the duodenum. In annular pancreas, the bile secretion is proximal majority of the times. बेटा बिलियस का मतलब जिसमें बाइल आएगा, नॉन बिलियस का मतलब जिसमें बाइल नहीं आएगा, और राइट हाइपोकॉन्ड्रियम मतलब जो हमारे पेट के दाहिनी तरफ का ऊपर का हिस्सा है उसको राइट हाइपोकॉन्ड्रियम. Last year from Davao beta, your query, hypokalemia is resulting due to potassium via urine. Yes, loss of potassium. That's right beta. Thank you very much. Muhsina from Wuhan beta. MCQ's answers. May I know which sources you are using here? Ideally, beta, Anandita, for any breast lump, we should do the complete triple assessment of CRP. ERCP beta is endoscopic retrograde cholangiopancreaticography, HAVA from UV glass. In ERCP, we are passing the endoscope from the mouth that is going through the esophagus stomach into the duodenum. And in the second part of the duodenum, we push the contrast into the bile duct and the pancreatic duct and take the X-ray. This is what is endoscopic retrograde cholangiopancreaticography. MRCP, we don't use any endoscope or anything. It is simple MRI of the abdomen where special emphasis is made on the biliary channels. Bile itself acts as a contrast in MRCP. Tarun from Orenburg. In duodenal atresia beta, why pyloric sphincter do not dilate? Because that is a constriction of muscles. The muscle power is more. So that is why it cannot dilate. It will rupture if you increase more pressure there. Double bubble sign, yes. Majority of the times it will be double bubble sign only. Otherwise, if the pressure is so high, then it may cause rupture of maybe the duodenum or something to release the pressure. In thyroglossal cyst, what secretions are accumulated? No, beta, the mucosa is secreting the mucus, so that mucus may get collected in the thyroglossal cyst. Swati from Harbin. Basically, sequestration of jugular lymph sacs is just an aggregation of the lymph sacs. Basically, there are lymphatic bags, you can say, near the junction of the jugular and the subclavian vein. These lymphatic bags, they join with each other, and that is what is aggregation of lymphatic sacs in cystic hygroma. Retrognathia means the jaw. Gnathia is for jaw. So the jaw goes inside. It is aminodiacetic acid beta, which we use as isotope in HIDA scan. Thank you, Rohit. Thank you so very much. God bless you. Manu from ISMU. ISMU, is this Irkutsk beta? Ectopic thyroid tissue is apart from the thyroid, normal thyroid tissue which is present in the neck. Sometimes we can find thyroid tissue here and there. We can find this thyroid tissue on the tongue, that is lingual thyroid. We can find thyroid tissue in the middle of the neck in the thyroglossal tract region, that is a median ectopic thyroid. I hope you heard the explanation about metabolic alkalosis and paradoxical aciduria. If not, Then I'll see in which query I have answered that, and I'll share the voice note with you. Akshay from Raizan, beta. The difference between hepaticojejunostomy and Kasai. In hepaticojejunostomy, we are doing it for type 1 biliary atresia, where CBD is absent. That means the right left hepatic ducts and common hepatic duct is present. We just connect the common hepatic duct with the jejunum, and that is a hepaticojejunostomy. Since we are making it in a letter Y, we call it as Ru and Y hepaticojejunostomy. While Kasai operation is being done in type 2 and type 3 biliary atresia, where we don't get any length of the bile duct coming down from the liver. Like in type 3, there are no right left hepatic ducts and the common hepatic duct and common bile duct. So we directly take the jejunum and put directly into the liver. That is Kasai operation. Aside, the complete topic of breast cancer will be taught later. You can just scroll in the workbook at pages somewhere around 215 and you will find all the breast cancer there. Dipanjali from Kiev, beta. In biliary atresia, biliary channels are absent, especially CHD. Then gallbladder is also not there, beta. In biliary atresia, is the bile coming out in peritoneal cavity? No, ducts are not open, beta. They are not present. They are closed. Abhishek from, I guess, Orenburg in Ramstedt seromyectomy. After making, what is the next step? Are we suturing it or connecting with the jejunum? No, beta. We are not connecting it with the jejunum. We are not suturing it. We have not created a perforation. We have not gone into the mucosa. We have just relaxed the serosa and the muscle layer of the pylorus. In HIDA scan, if the radioisotope is not excreted from liver, then it will be absorbed into the blood and then it will be going through the kidneys and out. Actually, in false aneurysms, high pressure will force the intima to create spaces between the media, and that is how it is going to go out. Mahesh, we provide 15 subjects workbook. We committed 14 plus subjects. However, physiology, there are no workbooks available with us. Radiology, there are no workbooks available with us. And CVS, CNS workbooks in medicine are also not available. So we are not providing these workbooks to any of our students, whether offline or online, beta.
Hello.
हाँ जी मैम, गुड इवनिंग.
Good morning. Good evening, sir.